Afternoon, Madam Chair.
Got to do it again. Good afternoon. Thank you for visiting the Senate Finance Committee. Today is March 4th, and we are going to hear 11 bills today with about 80-some witnesses. Sponsors, you have as much time as you need to present your bill. Witnesses, you have 2 minutes. Please honor the time limit. We have a lot of people to hear from today. And here is the bill order. Senate Bill 840, 740, 945, 876, 751, 748, 741, 920, 790, 900, and 720. That being said, the list is always subject to change because you'll see my committee members coming and going as they go to other committees to testify, or sometimes we're waiting for someone from another committee. So we do the best that we can to move through the schedule as planned. So we're going to start today with Senator Mouts, Senate Bill 840, and you have one panel member, Ron Forsyth.
Yep.
And this is Medicaid Management Information System Surveillance and Utilization Review. So, Senator, welcome.
Thank you, Madam Chair. Is it okay if we have the panel and we testify together? It'll be quicker. Thank you, Madam Chair, Mr. Vice Chair, colleagues. It's an honor to present Senate Bill 840 today. I'm going to read the title nice and slowly. Medicaid Management Information System. There's a lot of technicalities in this legislation, but it's a very straightforward proposal. That acronym is MMIS, Surveillance and Utilization Review Subsystem, and that acronym is SURS. Okay. The rest is pretty straightforward, Publication of Procurement Schedule. So this MMIS and SURS together is the essence of what this bill is trying to address. What the bill says explicitly is it requires the Department of Health by October 1, 2025 to publish on its website a schedule for the issuance of a solicitation for the procurement of a SURS, Surveillance and Utilization Review Subsystem of the Medicaid Management Information Systems, that's MMIS, at least 60 days before the issuance of the solicitation. MDH must publish on its website written notice of the contracting procedures, requirements, and timetables. Now, this probably appears first to be redundant because we have a procurement system, and you're probably wondering, why in the world, Senator Mouts, are you bothering us with this now? Well, this is a classic situation where you have sole source after sole source after sole source, and it has been glazed over with negative legislative audit after negative legislative audit after negative legislative audit. It is a serious issue within the Department of Health. However, it's so complex that it hasn't gotten the attention of policymakers. And the intent of this legislation is not only to bring our attention to the significance of this contract, but to force the Department of Health to get ahead of this solicitation and end the practice of the sole sourcing. Now, I am in no position to be able to testify about the intricacies of the procurement or of the contract, but I have an incredibly versed expert witness, Mr. Forsyth here, who will provide that for the committee. So with that, I'd like to turn the microphone over to Mr. Ron Forsyth.
Good afternoon. I'm Ron Forsyth. I'm the CEO of Clarent Corporation. Clarent is the national leader in program or detecting and investigating fraud, waste, and abuse in the nation's Medicare and Medicaid systems. We have 600 highly skilled employees located primarily on the Eastern Shore of Maryland. We hire lots of data analysts, physicians, nurses, data scientists, statisticians, and others. Being the national leader in program integrity for fraud, waste, and abuse in the Medicaid systems, we are very supportive of this particular bill moving forward, in that there have been a number of years that the utilization, the SURS contract that's currently in place has essentially been extended for approximately 7 years beyond its original 4-year term. There was an attempt to actually do a procurement that failed miserably. And all said and done, when you're looking at the total cost, you're looking at a 7-year extension of a legacy system that is outdated, that has cost the state approximately $2.5 million and counting. The failed system that was attempted to be procured back in 2019 cost an additional $1.5 million. But the biggest loss for the state of Maryland and for our taxpayers and for our Medicaid beneficiaries is that the fraud continues to go unchecked and just money flowing out the windows. And that's estimated to be for the state's $15 billion in Medicaid spending. If you take a low-end estimate of about 4.5%, you're looking at about $600 million a year that's going undetected and out the window. And so what we're looking for, the most recent extension for the procurement occurred 2 years ago when basically the state acknowledged that the previous procurement had failed miserably. But that deadline is now August 2025, and there's nothing on a procurement schedule indicating that something will be taking place at this point. So it's kind of critical and vital that this move forward.
Thank you. Do I have any questions for the senator or this panel? Senator Haight.
Thank you, Madam Chair. Senator Mouse, the testimony from the department says that the solicitation will be issued in the next 60 to 90 days, but the bill proposes October the 1st, 2025, which is way after such date. I guess, have you had the opportunity to have a conversation with the department about the release of the solicitation? Because it sounds like the introduction of the bill may have motivated them to move forward.
Thank you, Mr. Vice Chair. No, I have not had a chance to speak with the department about that. However, as an effort to sort of short circuit the procurement process by issuing the solicitation right now, in other words, to get in front of this legislation to sort of make it moot, I would suggest amending this and making it set, codified, that in the future, that's great. If they can offer the solicitation now, that's great. But moving forward, making sure that there isn't an opportunity for this to go through a solicitation and then revert to sole source again because of the problems that have been identified and the amount of funding that's not being detected through fraud and waste. Would it be okay to let my expert witness comment on that?
No, I think you've explained it enough. I guess the second question, and maybe the expert witness could testify to this, in order to do a sole source in procurement here in the state of Maryland, you have to have a justification of the uniqueness of the contract. What explanations been provided in the pursuit for doing a sole source procurement?
So the previous solicitations, the original contract period was from 2014 to 2018. That original contract period ended for the legacy system. Essentially, there have been sole source extensions for the past 7 years as the state tries to get its procurement in place.
Was there an extension on the original contract that allowed them to extend it, or was it actually a solicitation of a sole source, which is a very specific procurement mechanism?
It was not a sole source extension. It was essentially going to the Board of Public Works and getting authorization and approval for the continued extension.
No, the question is, was there an extension on the original contract? Most contracts that the state will issue say that you have a contract for these 4 years with the option to extend it for an additional 8 years or so. And so if it sounded like it was going to the Board of Public Works, it sounded like they were exercising their contractual obligation to extend it and not doing a sole source.
The contractual obligation ended in 2018. All of the other essential extensions that came after that were because you actually need to have a SERS system in place in order to receive your Medicaid funding. If they let the contract lapse, the state would have been in kind of deep trouble.
Gotcha. Thank you, Madam Chair.
Thank you for those questions, Mr. Vice Chair. Do I have any other questions from this bill? Senator Ellis.
Yeah, thank you, Madam Chair. Interesting bill, Senator Mounts. Question for you, Ron. So you said your company have, what, 100 plus employees?
About 600 employees total.
Okay, and and what's the main purpose for your company? What's the main?
Probably 80% of our work is looking at program integrity, fraud, waste, and abuse in Medicare and Medicaid across the country.
Yeah, okay. And how do you make your revenues to pay your bills?
A lot of our revenue comes from federal contracts. We are the largest contractor for CMS doing Medicare, Medicaid fraud detection and investigation.
Okay, interesting. I didn't know that was an industrial segment.
Yeah, we're based in a front yard of Maryland in Talbot County.
Okay, nice.
So we have about 25% of our employees are Maryland-based, and
Right, okay, well, congratulations. Thank you, Madam Chair.
Thank you, Senator. I don't see any other questions. That ends the hearing on Senate Bill 840.
great. Thank you.
Thank you. Is Senator Folden here? Okay, Senator Folden, you're next. Healthcare Facilities, Warrior Community Members. And you have a panel with Jessica Fast and Brittany Morris, and I hear you have a 4-minute video.
Yes, ma'am.
Okay.
If you don't mind, I appreciate your indulgence, Madam Chair.
You can begin whenever you're ready.
I'm just gonna do a brief introduction of the bill. Thank you. Have a seat. Have a seat. Who's this? Who are you, sir?
He's a member of NAGM with me.
Oh, okay, I didn't know. He was, so, Madam Chair, Mr. Vice Chair, esteemed colleagues, Finance Committee, for the record, William Folden, State Senator representing Frederick County. Before you today, I have Senate Bill 740, the Sergeant First Class Matthew FAST Act for Warrior Healthcare. And before we really get into this, I just wanted to introduce the bill, and I wanted to show a short video that kind of will drive home exactly what we're trying to solve here so that it doesn't happen to any other of our warrior community in Maryland. So with that, if you could just play the bill. Thank you. It's okay. It's okay.
That I was really.
Yes, that would be it. And the volume. Yep.
I did not grow up at all with a military background. And so it really wasn't until I met Matt, my husband, that I was really introduced to this whole world.
Say hi, Fast.
Both deployments were similar in Iraq and Afghanistan. He was an MP, or military police. He later went on to the police academy and became a police officer, and he was still in the reserves. I actually remember very vividly that weekend. I could tell he wasn't right, but he wasn't complaining. He sort of had that typical soldier attitude of soldiering on, of just, continue through the day. And so I said, let's just go to the urgent care. And he told them that he wasn't feeling well, said that he had some sort of heaviness on his chest, and said, but it's just strep throat. Somebody else on my squad had strep throat. That's all it is. And they did 2 different strep tests. And they said it's not strep. So we recommend some over-the-counters and a lot of rest. In the middle of the night, I heard what sort of just sounded like loud breathing, and I'm sort of nudging him, thinking it's snoring. And he's not sort of moving or acknowledging. And so I'm nudging him and nothing. And I hear this sort of like breath, like a big breath. And then we buried him the following Monday. it wasn't possible. Like, I know everybody says there's no way that could happen. He's healthy, all these things, or he's young, he's invincible. The story didn't play out that way. That wasn't how the story was gonna go. It wasn't until years later that I really started to look into it and wonder how this happened. I'm looking at everything. I am 2 a.m. researching anything I can find. And so it really was trying to piece together a massive puzzle. Both deployments were similar. There were high levels of toxins. That was not something that would be allowed here in the States. So he was breathing that in, and he was right there. He ultimately passed away from myocarditis, which is a scarring of the heart and the lung tissue. I think we know more and more that it's causing issues that might not be impacting people today, but if you think about myocarditis, that alone is something that people can have quietly. And what happened was he just got a viral infection, and his body was not able to handle that. He literally was at work the day that he came home and never woke up. I think my husband's reluctance to talk about it is probably a shared experience with a lot of veterans. You're sort of taught to keep going. Had they asked the question, had somebody made a connection of, this person's sick, they're complaining about their chest, and they were also deployed in a combat zone, we might want to do additional testing. Any raising of the hand to say, I think something's wrong, is deemed weakness. And I think that's what I would change, is to remove the stigma of weakness around saying I'm not well.
So this bill is personal to me. So Matthew grew up around me for probably the first 12 years of his life. He lived at my home quite regularly. And to this day, I still wear Matthew's bracelet. He was 29 years old. 29. The Sergeant First Class Matthew FAST Act for Warrior Healthcare requires Maryland healthcare facilities to systematically identify and respond to the unique needs of veterans, service members, and their families, collectively called the warrior community. By designating this population as vulnerable, the bill would mandate screening and better data collection to prevent misdiagnosis, improve outcomes, and honor the service of those who have served or are serving. This approach aligns with existing state and federal healthcare equity requirements, ensuring minimal administration or administrative burdens and maximum inputs or outputs in patient care. I did want to call in the question real quickly about the fiscal note. I was kind of shocked to see the fiscal note at $600,000 or whatever it was for something that is as simple as requiring a doctor to ask, did you serve? Because if they ask that and they ask where you served, there may be a logical connection that could save the next life, like it could have saved Matthew's. Because had they known, so most, I guess probably 80% of veterans don't go to the VA because they either feel like they don't get the proper treatment or inferior treatment. But This addresses the civilian care gap. Because of that 80% of the veterans who receive some or all their health care outside the VA, it would make a systematic screening crucial to connect these dots. It leverages existing frameworks. The bill aligns with the current state and federal standards to address health disparities. Screening for military service helps providers catch conditions related to combat exposures, toxic substances, and stress before they become critical. And it also honors Sergeant First Class Matthew Fast's service and his memory. This legislation was inspired by a preventable tragedy, turning a loss into a commitment to protect other warriors who have served, and it protects their families. You're going to hear from Matthew's wife, who's here today. His mother is here, his mother-in-law is here, and his son, which is the most... Jessica found out she was pregnant the week after Matthew passed with their first child. So Matthew doesn't get the opportunity to see his son grow, but I get the opportunity to see a whole nother Matthew because he looks and acts just like him. So in a lot of, it's definitely our blessing. So with that, Madam Chair, I would just ask that this warrior community, Maryland has about 500,000 veterans and service members, and I would ask that we do our part, our small part, to ensure that a simple series of questions or a question is being asked of our warrior community so that we can ensure the proper health care decisions are being made in saving the next Matthew Fast. And with that, I would ask your favorable report on SB 740.
Thank you, Senator. Jessica, and I'm very sorry for your loss, but we'll be happy to hear your testimony.
Always difficult to follow that. Good afternoon. Good afternoon, Chair Beidel, Vice Chair Hayes, and esteemed members of the Finance Committee. Sincerely thank you all for having me here today and allowing me to put forth my husband's memory in a way that can really impact the lives of so many. I also want to extend my heartfelt appreciation to Senator Ellis and Senator Folden for their military service, as well as recognize Senator Guile and Senator Maltz for their important role as military families. Each of you have demonstrated a steadfast commitment to supporting and championing the warrior community. Senator Folden, thank you for your leadership on this legislation on behalf of the warrior community. The work that you do in these halls is so incredibly important. But what I also want to recognize is what you do outside of these walls for our family, for your family, for so many families. And I'm so grateful, and I'm so grateful that my son has you to look up to just like his father did. I'm here today to testify in support of Senate Bill 740, the Sergeant First Class Matthew Fast Act for Warrior Healthcare. As you saw in that video, he was 29 when he passed away from what we thought was just a cold heaviness in his chest, nothing that was out of the ordinary. 3 days after taking him to an urgent care clinic where he was told he didn't have strep throat, he was sent home to rest. He went to work Monday, Tuesday, Wednesday, and Wednesday night he passed away in his sleep. He was incredibly passionate, both as a service member, but also as a police officer for our community, and was very, very, very much an advocate for our state of Maryland, always wearing the flag. Am I done? Okay. So I just wanted to thank everybody here for listening and just advocate that this bill takes a critical step towards helping our healthcare system better identify and care for patients without imposing an undue burden on the state budget. And I urge this committee to vote in support of SB 740 and help us protect the health and future of those who have given so much.
Thank you, Jessica. Brittany Morris.
Good afternoon, Madam Chair, Vice Chair Hayes, and members of the committee. I'm Brittany Morris, Vice President of the National Guard Association of Maryland. We're honored to come before you today to support Senate Bill 740, the Sergeant First Class Matthew Fast Act for Warrior Healthcare. This legislation ensures that Maryland's healthcare facilities screen patients for military service and document that status in their medical records, aligning with national patient safety goals to improve care for service members, veterans, and their families. Many civilian healthcare providers lack awareness of military-related health risks, leading to misdiagnoses and inadequate treatment. This bill addresses the gap by making military service screening a standard practice, ensuring that those who have served receive informed, appropriate care. Military service is a key social determinant of health, affecting both physical and mental well-being. Veterans and service members face unique risks, from toxic exposures and combat injuries to psychological stressors that civilian providers often overlook. More than half of U.S. veterans rely on civilian health care, yet many providers never ask about military history, missing critical health factors. As the National Academy of Medicine has highlighted, failing to recognize military service in healthcare settings results in suboptimal outcomes and disparities in care. By requiring providers to identify warrior community members and integrate that information into treatment decisions, this bill closes that awareness gap and improves care quality for those who have served. This bill is a practical, necessary step to ensure Maryland's healthcare system properly serves its military community, and it standardizes military service screening across facilities, leading to earlier diagnoses, more tailored treatment, and better long-term health outcomes. By passing this legislation, Maryland can set a national example and supporting those who have sacrificed so much for our country. The National Guard Association of Maryland urges favorable report on SB 740 to ensure all service members, veterans, and their families receive the quality care that we deserve.
Thank you, Brittany. Now, this is the sponsor panel. Do we have any questions for the senator or his witnesses? Seeing no questions, thank you very much, Senator. We have two more favorables at the table, Ronald Steptoe and Evelyn Lewis.
Can you push that one? Yeah.
Okay, sorry.
Hello, can you hear me? Very great. Chairperson, Vice Chair, members of the committee, Senator Ellis, sir, appreciate seeing you again. Thank you for this opportunity, and Jessica, Senator Folden, thank you very much for your championing this effort. My name is Ron Steptoe. I'm a 34-year resident of Maryland. I am a veteran, West Point grad, and my family legacy of military service dates back 8 generations to the Revolutionary War and Civil War. I've also spent 17 years as a principal investigator working with the Department of Defense on health-related issues, specifically looking at health disparities for our service members and focused on how can we improve the care. The key thing that I think is important to note is that, as noted before, that the majority of service members, veterans, and their families actually get their care in the commercial healthcare sector. 80% of National Guard and reserves and their families are again in the commercial sector. Only 57% of hospitals ask the question, have you served? And less than 10% do anything with that information. So that is what really creates the gap. That's critically important when we look at the PACT Act and the fact that the PACT Act has now emphasized the importance of toxic exposures. This is also personal to me. At the age of 57, I was diagnosed with prostate cancer, something that normally happens at the age of 67. LifeBridge, Chesapeake Urology, as well as MedStar, where I had my surgery, none of them had my medical record that I was a veteran. The reason this is important is because 1 out of 8 males will be diagnosed with prostate cancer. 1 out of 6 African Americans will be diagnosed with prostate cancer, and that was their focus. Yet 1 out of 5, I say again, 1 out of 5 veterans are diagnosed with prostate cancer. And my wife and I had to take on understanding what was the best treatment for me with that additional risk. So as a professional, as a citizen, I urge you, because this is a national security and public safety issue. As a veteran, I beg you to move forward with this legislation. And as a cancer patient, I implore you to please provide us some help. Thank you.
Thank you, and thank you for your service. And Ms. Lewis?
Good afternoon, Chair, Vice Chair.
Microphone over, please. There you go. It's very flexible. Thank you.
Hear me better now? Thank you. Good afternoon, Chair, Vice Chair, and members of the committee. I'm Dr. Evelyn Lewis, a family physician with 25 years of experience caring for those who have served our nation. And I continue doing so as the president and chair of the Veterans Health and Wellness Foundation. I strongly support the Sergeant First Class Matthew Fast Act for Warrior Health, a life-saving measure to close dangerous healthcare gaps for Maryland's 1.3 million members of the warrior community. Our warriors face alarming health disparities. Things like PTSD rates are 115% higher, chronic pain 32% higher, cardiovascular disease 39% higher, and hearing impairment a staggering 380% higher than the general population. Yet over 80% of our warriors receive care in the commercial facilities where providers often lack training in military health. While 71% of providers agree that asking, "Have you served?" is crucial, only 19% consistently do so. Without this key question, critical diagnoses are missed, treatments are ineffective, and preventable healthcare crises occur. The Sergeant First Class Matthew Fast Act mandates universal screening for military service in all Maryland licensed healthcare facilities, ensuring our warriors are identified as a vulnerable population. It also requires annual reporting on warrior health disparities, fostering accountability and continuous improvement. I have seen and experienced firsthand the struggles veterans face when military history is overlooked. This common sense, cost-effective solution not only improves patient outcomes, but also honors our promise to care for those who have borne the battle. Maryland has the resources and the moral obligation to deliver excellence in care to our military community. I urge you to support the Sergeant First Class Matthew Fast Act. Thank you.
Thank you. Do I have any questions? Senator Reedy?
Thank you, Madam Chair, and thank you to all of you for your service and sacrifice. We do appreciate it, really, and words are not really enough to express that. Mr. Steptoe, I was curious, this all sounds great, and I think a lot of us would want to do something here, but that we do have, anytime we have stuff dealing with hospitals, we obviously have the issue of Maryland's system is somewhat unique with the all-payer system and the total cost of care model. And I know you're familiar with all that, I'm sure, with your experience. I mean, can you talk about how this bill, is this bill going to add additional problems for that? Or how do you foresee this bill working with the all-payer model?
Well, sir, thank you very much, Senator, for your question. If we look at the all-payer model, when we look at the fact that only, again, hospitals aren't asking the questions, it does wind up being a challenge for the state of Maryland in the long term, because again, if we look at these health conditions that are not particularly looked at from a preventative perspective, or at least begun to get managed, as service members get older, they're going to wind up, these conditions can wind up becoming more complicated. So the fact that we are not catching these conditions early enough, managing them appropriately, winds up being a cost that the state is going to wind up bearing in the long term by not actually addressing these up front. The other component, when we look at the cost to the health systems, many of them already have community benefit, which they're already supposed to look at vulnerable populations, and many of them already have the national patient safety goal that they need to be moving forward with.
Apply to that?
Yeah, that is absolutely correct.
Okay. All right. And then with the benefit for hospitals, is there's no opposition from the hospitals, sort of be clear. I always know what comes up as we discuss these bills. What is the hospitals, of course, want to care for patients, but also there's some benefit, as I understand it, from a hospital. Can they be recognized by the federal government? Is there a way for them to get additional recognition for supporting this kind of effort?
Well, a few things. One, many health systems are looking to either contract with TRICARE, so they could wind up having a lot more hospitals be in network with TRICARE, which is the DOD's component of that. When you look at the VA, again, the VA is looking as more and more care is going out into the community. What health systems may, the VA, as again, more folks are being looked at for the PACT Act. Many of the VA hospitals and medical centers cannot actually care for them. So again, a lot of that care could go into the community, which would provide additional revenue for the hospitals in reference to care. So there is an opportunity for additional federal funding coming into our hospitals as the VA is trying to manage these exposures that are now being recognized and the chronic treatment associated with that.
Okay. Thank you very much.
Thank you for the question, sir.
Thank you. Senator, we have an idea, Council, Nathan McCurdy has an idea to how to save this fiscal note, because, you know, we can't really pass anything that has
Yeah,
more than 100,000. So watch for an email from
Wonderful.
Mr. McCurdy, and
Really
we're
appreciate
going to
it.
work on this. Thank
Really
you.
appreciate it. Thank you.
Thank you.
Thank you, Madam Chair.
So no other questions. That'll end the hearing on Senate Bill 740. And now we're going to go to Senate Bill 945.
Thank you.
Senator Heddleman is here. And Senator, you do not have a panel, so it's all you. Thank you.
This should be a quick one today. Madam Chair, Mr. Vice Chair, members of the committee. For the record, I'm Shelley Heddleman, Senator from District 11, and I'm here today on Senate Bill 945. This bill is really born out of a little bit of frustration in our communities. I regularly hear from constituents who are frustrated when they don't know who to call in government. I had a woman who lives in a townhouse community who walked out to get in her car and realized that there was glass that had been shattered all over her driveway from the home next door. And the home next door was a group home. We don't know who it was registered. We don't know what kind of group home it was, but she called the police, she called local code enforcement, and she couldn't find out who was the one who was ultimately responsible for taking care of the home and ensuring that her driveway wouldn't be blocked by the neighbors' cars that would park in front of it, who was going to clean up the glass from her driveway, et cetera. And I know in my neck of the woods, and I believe in the 41st District in Baltimore City and in the 10th District in Baltimore County, we have a lot of constituents who are similarly frustrated. And so this bill is really an attempt to help people get information. Now, we're not interested in knowing why the home is licensed as it is. We're not interested in knowing particular information about the individuals who reside there. We're just interested in having a state agency be responsible and be attentive to the concerns of the neighborhood. So while the fiscal note talks about an individual who is responsible for being that point of contact, it could be the office that already exists. I will tell you, I spent a little time on the Maryland Department of Health's website the other day to try and find out how is it that somebody can navigate the system to know who they should file a complaint with. And it was really frustrating. There were a lot of dead ends to get to. All we're asking for is that there be one point of entry listed on the website. If there are concerns or complaints, call here. And again, we don't even know that it's definitely the Department of Health. Sometimes it's the Department of Juvenile Services. It might be different agencies within the Department of Health. But there are different entities that license these homes, and people should be able to live in our communities like anybody else, and they should be good neighbors. That's really all this is about. Somebody who was in my office who was concerned about this and who said, well, what do you do if your neighbor is throwing trash on your lawn, or, you know, the same situation? And you'd be able to call the police, or you'd call local code enforcement, and they would hold them accountable. The same does not hold here. And so while people who live in group homes should be able to live freely, and we in the community like any good neighbor, they should also be held to the same standards that everybody else in the neighborhood is held to. And that's all this is about. It's about being good neighbors, and it's about allowing folks the opportunity to know who in the state they can turn to if the state is the one who's ultimately responsible for licensing the home. So that's all it's about, and I ask for a favorable report. Thank you.
Thank you, Senator. Do I have any questions for Senator Heddleman? Seeing no questions, thank you, Senator.
Thank you.
We have one witness unfavorable, Matt Rice. And then I'm going to note that Randy Ames from Disability Rights Maryland has written testimony and wanted to be here but not feeling well. So thank you for not exposing us all to whatever you're not feeling well about. Matt Rice.
Thank you, Madam Chair, Honorable Vice Chair, members of the Senate Finance Committee. For the record, my name is Matt Rice. I am the Executive Director of People on the Go Maryland, which is Maryland's statewide self-advocacy organization for people with intellectual and developmental disabilities. I'm also here representing the Developmental Disabilities Coalition, 5 statewide organizations dedicated to advancing the rights of those with intellectual and or developmental disabilities. We're here in respectful opposition to SB 945 because the way we see it, this is much more than just allowing people to, be good neighbors and hold them accountable. What we see as potentially problematic is, first of all, the bill does require that the licensure requirements be posted, which that information is already available as it relates to Developmental Disabilities Administration services and supports. You can find that on their licensure and renewal page. But even more problematic is the requirement of a single point of contact. So I just want you to imagine for 1 second, you live in a group home. You require residential supports to live your life. And let's face it, if you are a person with a disability, you're accustomed to the stairs. You're accustomed to having people look at you differently than your peers without disabilities. So the way we see this is this could be a mechanism, however well-intended by the sponsors, for people to have a not in my backyard mentality when it comes to licensed residential facilities. And with that, I ask you respectfully for an unfavorable report.
Matt, thank you for your testimony. Do I have any questions for Matt? No? Thank you for being here today.
Thank you.
Thank you. So that ends the hearing on Senate Bill 945. And our first change of the day is Senator Hershey's in another committee, so we have Senator Henson here. Senator, thank you for coming up. We're going to hear Senate Bill 751, Health Facilities, Assisted Living Programs, Family Councils. And Senator Henson's going to bring Tammy Bresnahan, George Carroll, and Darlene Gillespie with her.
Thank you, Madam Chair. Thank you, members of the Finance Committee. For the record, I am Senator Shanika Henson, here to present Senate Bill 751, Health Facilities, Assisted Living Programs, Family Councils. Family councils are already a feature at our nursing homes, but not yet at our assisted living facilities. What this bill would do is authorize the owner, operator, or staff of an assisted living program with 15 or more beds to create a family council, which is a group of individuals who work together to protect the rights of and improve the quality of life for residents. An owner, operator, or staff of an assisted living program may also lead that family council for up to 6 months, at which time a member of the family council must then assume authority and lead the council. I want to compliment the Department of Health on their leadership on this. We have been working with the Department of Health, and they do have several regulations that they are promulgating that would address this area. I believe you have an info letter from the Department of Health, and I'll just highlight some of the differences between this bill and their plan. They say in their info letter in the 4th paragraph, as such, the department believes the intent of this bill is encompassed within the proposed regulations, which MDH plans to adopt following the completion of the public comment period. The department's family council regulations apply to all assisted living programs regardless of bed size, so that's the first difference. Residents Council and allows for 30 days to respond to the grievance. That's the second difference. Senate Bill 751 applies only to assisted living programs with 15 or more beds and does not address a resident council, and it also gives 14 days to respond to the grievance, not 30 days. So there are some differences. We do appreciate, again, the department's efforts on this, but with that, I'll put it for the committee's consideration and ask for a favorable report on Senate Bill 751. Thank you.
Thank you, Senator. We're going to hear from your witnesses.
Good afternoon, Senator Vital and Vice Chair. My name is Darlene Gillespie, and I represent the Elder Care Advocacy Group of Central Maryland. The reason we came today to talk to you is this is personal for both George and I, but I want to speak on a little more personal basis. We have firsthand experience from what it's like to have a family advocacy group in our assisted living. And I'm speaking in memory of my mother-in-law, Henny Madsen. She was in assisted living for 7 years. And at the time of her death in 2022, the cost of her care totaled $460,000. So you may be saying, well, what's that got to do with this bill? And I'll explain that at the end. A family council was established quickly after she arrived. It was very purposeful for many years. Family members established positive relationships with administration and staff members. We all worked together as a team to make sure a lot of issues were addressed. They were a great opportunity to serve as venues for daily operations that related to her care, such as dietary issues, pharmacy issues, and housekeeping issues. Communication between the members of the family council and the facility director was critical and crucial. I was hoping to attach some attachments to this so you could see how the responses go to that, but it wouldn't transfer to PDF, and I wasn't able to do that. But often the response from the director was more than 30 days. The intent of the council remained foremost as we were able to accomplish many positive changes, such as dietary options, locked closet for storing pens, name tags for staff. Because we were able to deal with these concerns in the confines of family council, we did not have to go to the ombudsman who was needed to deal with bigger complaints and concerns such as abuse and injury investigations. The ombudsman was always available to us if we needed her, and we consulted her. We invited our local hospice and chaplain to attend our meetings. So many have said that why do we need legislation when we have this in the COMAR regs, as Senator Hansen already addressed. But we feel this bill is more comprehensive, and it also encourages more communication between the Family Council and the family assisted living. Senate Bill 0751 identifies the importance of a 14-day response for the administration. And just because they're responding in the 14 days does not mean that they have to have a solution within those 14 days. And what we found is a lot of times they would go to the 30 days.
Need to wrap up.
Yes, ma'am. So in closing, as I mentioned, I would explain to you about why the cost was so much, because we didn't have family council. A lot of these issues that became important, we had to address, and it became increased her level of care, which upped our cost up to sometimes $1,500 a month. I hope that you will vote in support of Senate Bill 0751. Thank you.
Thank you. Mr. Carroll.
Okay, thank you, Chairman Bottle. Yes, I'm George Carroll. I'm also a member of the Elder Care Advocacy Group of Central Maryland. And I want to be the first one to wish you all happy Mardi Gras. My written testimony describes how the family council at the facility my mother lived in for over 3 years helped the residents there. I think that's been delivered to you folks. It describes all the different problems that were solved or at least addressed by family council. My oral testimony here today addresses the deficiencies in the recently revised regulations. Number one, the time to respond of 14 days is identical to the current regulations for family council in nursing homes. My personal experience is that written responses to a family council suggestions or grievances were no different at 14 days than they were at 30 days. Number two, recently updated regulations had no notification requirements for the facility to tell current or prospective residents of the possibility of having a family council. Number three, the written correspondence between the assisted living facility and the family council is not available for view to prospective residents or their families as required in this proposed Bill SB 751. This would educate and inform prospective residents of the problem-solving record of the facility with regard to family council grievances. Number four, This process to revise the regulation has taken almost 10 years. It's important to get it right. This bill will help improve the new regulations. Number 5, the Department of Aging has consulted with a well-known lobbying group that the representative of AL industry to put forth the finishing touches on this revised regulation. The lobbying group is not primarily focused on the residents' needs. This legislature must give voice to the vulnerable residents of these facilities, and I thank you.
Thank you. Do I have any questions for any of these witnesses? I have a couple questions. I'm just curious, how large, Mr. Carroll, how large was the nursing home that you had a loved one in?
I think there was probably 80 or so residents.
80, that many? How about you, Ms. Gillespie? How many?
They were in the same assisted living.
They were in the same assisted living?
Yes.
So you had, I'm just a little concerned about the 15-member, Senator, because it's hard to get people to volunteer. So, you know, you have a family council, but if nobody comes, then what happens?
I believe the posture of the bill is that it's enabling, so they could establish a family council, but wouldn't be required to.
Thank you.
Thank you.
My dad just spent about almost 2 years in an assisted living, and I know some of the issues that we see, and if you aren't there advocating, things get a little out of control, and so it's hard for families that aren't nearby. So thank you for this legislation. Do we have any other questions? No? Thank you very much for your testimony.
Thank you, Madam Chair. Thank you, members.
We have one unfavorable from Dana Kaufman. Dana?
Good afternoon, Madam Chair, members of the committee. For the record, I'm Dana Kaufman on behalf of Lifespan Network, and I want to be very upfront. We do not oppose family councils, but I did want to make sure I was able to come to the table, so I didn't want to just put in a letter of information, so that's why I signed up opposed. As it was mentioned, we have been working on the proposed regulations since 2016, for 9 years. And the comment period just ended on February 24th. And Lifespan's comment was, please enact these regulations. It has been a very long time coming. They have been vetted many, many times with a very large stakeholder, very open process. And they did increase the responsibilities and the structure around family councils. And our ask is that we allow the regulations to go as is. Everyone now, there was nobody, to the best of my knowledge, opposed this provision. So we would like the regulations to go forward as is. If there's a problem that we need to address later, we can always come back. But there are differences between the two, which would require a regulatory change. We think that the regs also recognize the difference between nursing homes and assisted living and accommodate that. So we would just ask to let the regulations go forward. Let's re-examine it if we need to, but not in this bill. Thank you.
So, Dana, you and I are very well aware of these regulations that we've waited for 9 years, that we already had 8 years, so it's been 17 years since we really revisited the regulations. So do the regulations include family council requirement?
Yes, so and I have them right here. The regulations do, and there is some, I went through them again today, and there is some overlap, but there are some inconsistencies, like you've heard, the 14 and the 30. But like there's a provision in the regs that is not in the statute or the legislation that says, you know, the assisted living program shall consider the family council's recommendations and grievances and attempt to accommodate those regulations and grievances that affect residents' quality of life. It talks about, you know, meeting space and requesting, you know, if they need assistance, because as you said, you can try to get a family council together. It doesn't mean you're going to be successful, but these regulations do encompass all the assisted livings, which we do think is important, because if you can get a family council together, you know, if it's 9 residents, it's a good thing.
Do I have any other questions for Ms. Kaufman? I'm sorry, I didn't see your light. Senator Jack.
Thank you, Madam Chair. Did you talk with the sponsor about any overlap?
Not with Senator Henson. I did talk to Delegate Weems in the House, who came to me with this bill several times and talked about the differences.
Okay, because perhaps, you know, if you have a conversation, you can work those things out. And
yeah. Duly noted. Thank you.
Thank you, Senator. I don't see any other questions. That ends this witness's testimony. Thank you, Dana. And now we have a virtual witness, Elena Salido. Elena, unmute, please.
Okay.
Now we can hear you. Thank you.
All right. My name is Elena Salido. I am an elder law attorney in Anne Arundel County, and I am the current president of the National Academy of Elder Law Attorneys. We are supporting this legislation. Very simply, it's just good common sense. Family councils are easy, inexpensive ways to protect the rights of vulnerable residents and ensure that their needs are met and they're getting the best quality of care, best quality of life possible. It should also help ease the burden on state regulators who are charged with inspecting assisted living facilities. Assisted living facilities with vibrant family councils and with a good interchange of information between families, residents, and facility and staff just make for a better running organization, thereby eliminating or decreasing the burden on regulators and state inspectors. I think it goes without saying that getting into an assisted living facility is distressing, and it can be a very isolating and overwhelming kind of situation. Family councils help balance that by giving people a voice that sometimes people are a little concerned about raising for fear of retribution. That fear is real, whether or not it's founded, but definitely does prevent people from speaking up when they should be or could be. We would urge that an ombudsman also be allowed to create a family council. Very often, the ombudsman is someone who has that more of an independent viewpoint, who's charged with advocating for the resident, and where the facility may be less than excited about having a family council, the ombudsman can step in and make sure or help assist that happens. I think it is important to note that this is not mandatory for the creation of a family council, but just allows them to do it, and would urge support.
Thank you. Do I have any questions for this witness? I see no questions. Thank you for your testimony.
Thank you very much.
That ends the hearing on Senate Bill 751, and Senator Hershey's back. So we're going to go back to Senate Bill 876, Maryland Medical Assistance Program coverage for the treatment of obesity. And Senator Hershey has three panel members, Monica Billinger, Dr. Nimgan Kaur, and Nikki Massey.
I don't know what I'm saying. Dr. Chaudhry is not here.
Senator, I think I called up your panel and there were three.
The panel of, I should have four, oh, yeah.
I know Mr. and Mrs. Chaudhry's not here, but
Ms. Chaudhry's not
Monica Billinger, Dr. Nimgan Kaur, and Nikki Massey. Is there?
Oh, okay. Do you?
Who's the fourth?
Mihir Patel. But Patel is on the list?
It's on the list, wasn't on your panel, but that's fine. He's on the
Okay.
list.
Is that okay? Okay.
That's fine. Go ahead.
Thank you, Madam Chair, members of the committee. For the record, Senator Steve Hershey to present Senate Bill 876, which is intended to allow the state Medicaid program to provide comprehensive coverage to treat obesity. So let's start with the facts. Obesity is not a personal failing. It is a chronic disease recognized by every major medical authority, and it is fueling a crisis in Maryland. It drives over 200 serious health conditions, from diabetes and heart disease to stroke and cancer. Yet Maryland Medicaid treats obesity different from other chronic conditions. We cover the expensive consequences like dialysis, amputations, and emergency surgeries, but we don't cover the treatments that could prevent those outcomes in the first place. What's worse, Medicaid is permitted to treat obesity with medications, but the trick is you must first survive a heart attack or stroke, and that doesn't make sense. Right now, Medicaid patients with obesity in Maryland have two options: diet and exercise, or bariatric surgery. That's it.
no access to prescription medications, even though research shows that they can help people lose 5 to 17% of their body weight, enough to dramatically reduce their risk of diabetes, heart disease, and stroke. Imagine if we treated high blood pressure this way, telling patients just eat less salt, and then waiting until they need heart surgery. Or a cancer patient we can't treat until they are stage 4, or telling a patient with asthma to try harder. That's exactly what we're doing with obesity. We are already paying the price for inaction. Medicaid is covering the cost of untreated obesity just in the most expensive way possible. Every year, we spend millions of dollars treating diabetes, heart attacks, kidney disease, and joint replacements that could have been prevented with earlier intervention. Studies show that treating obesity can reduce diabetes rate by 58% and cut the risk of heart attack, stroke, or cardiovascular death by 20%. These aren't just numbers. These are hospital beds, ER visits, and lives cut short because patients did not have access to treatment. The reality is, Maryland is already spending tens and likely hundreds of millions of dollars on the effects of obesity. We are paying for emergency room visits, insulin and diabetes medication, kidney dialysis, and heart surgeries. That's the status quo. The question isn't whether Maryland will spend more money on obesity. We already do. The question is whether we're going to spend it wisely. And this isn't just a public health issue. It's a health equity issue. In Maryland, nearly 42% of African American adults and 33% of Hispanic adults live with obesity. These numbers aren't just statistics. They reflect systematic barriers: lack of access to healthy foods, fewer safe places to exercise, and in this case, an outright exclusion of medical treatment from Medicaid coverage. If we're serious about addressing the health disparities, we must provide access to comprehensive obesity care, just as we do with other chronic diseases. And let's talk about stigma. Obesity is one of the most misunderstood and stigmatized conditions in healthcare. Too often, patients seeking help are met with judgment instead of medical care. Just eat better, just exercise more. That kind of thinking is outdated and frankly wrong, and certainly tone deaf when dealing with our most vulnerable population, Medicaid. The reality is obesity is largely driven by genetics, biology, and environment, not by willpower. If diet and exercise alone were enough, we wouldn't be in this crisis. This is a small but important step towards Maryland exploring and embracing anti-obesity medications as part of a broader strategy to help Marylanders and stem the rising cost of obesity in the state. Other major government programs, including the Federal Employee Health Benefits Plan, TRICARE, and the VA's health system, have already taken steps to provide access to obesity treatments because they recognize long-term cost savings, and Maryland should do the same. So, Madam Chair, if you remember, we had a very similar bill last year, and we made a change to make it a study, and we went to Department of Legislative Services and Department of Health to come back with a fiscal note. So if I can just stress the fiscal note very quickly. And another piece of advice, we were going to have an amendment on here that doesn't make it a mandate. So Senate Bill 876 was never intended to be a mandate, but it's a tool. However, the bill as originally introduced did not include the important amendment that allows Medicaid to determine utilization of obesity treatments. This inclusion of this provision would ensure that Medicaid retains the discretion to apply medical necessity reviews and other utilization management tools, balancing patient access with responsible fiscal oversight. By allowing Medicaid to determine when and how anti-obesity medications are used, this amendment ensures that the state is not committing to unlimited expenditures, but rather taking a measured, responsible approach to integrating obesity treatment. Moreover, as a point of clarification, if this bill were a mandate, the fiscal note would still be wrong. The fiscal note for Senate Bill 876 estimates an impact of $225 million in FY27. This is a significant improvement from the 2024 bill, which projected at over $1.1 billion. The problem with this estimate is that it continues to massively overstate utilization. In states that have covered anti-obesity medications for years, utilization remains below 3%. far lower than the 15% assumption used in the fiscal note. Even if Maryland reached the 3% mark, yearly costs would be no more than $17 million. Moreover, this estimate does not account for offsets, such as the reduction in diabetes treatment, fewer hospitalizations, and improved workforce participation, which could substantially mitigate cost. We are already paying the high cost of obesity. The choice before us is whether we keep paying more for preventative complications or take a smarter approach. In Senate Bill 876, with this amendment, it is a step towards better care, better health, and better use of Maryland's Medicaid and health care dollars. I urge a favorable report. Thank you.
Thank you, Senator. Who would you like to go next?
Thank you. Thank you, Madam Chair and all members of the Senate Finance Committee. On behalf of American Diabetes Association, over 500,000 Marylanders living with diabetes, we express our support for Senate Bill 876. Let's dive into the numbers. Diabetes is now the 6th leading cause of death in Maryland and a risk factor for other leading causes. Maryland is consistently in the top half of the U.S. with the highest diabetes prevalence rates. The most expensive chronic disease in our nation, diagnosed diabetes costs an estimated $7 billion in Maryland alone in annual medical costs and loss of economic productivity. But it's not just diabetes, as the senator mentioned. Obesity exacerbates over 200 medical disorders, and obesity increased Medicaid spending in Maryland by $304 million. And if we talk about last year again, this bill was originally at $1 billion. And now it's still overly exaggerated at over $200 million. If that were true, Maryland would certainly be a new kind of leader, especially when other similar states are showcasing other numbers. In North Carolina, the estimate is for $22 million in 2026, and that's with a higher Medicaid recipient participation rate. In Virginia, in 2024, they spent $36.5 million on their GLP-1 access and their coverage, and that was gross. That did not include rebates. Similarly, the American Diabetes Association analyzes utilizing publicly available health statistics from the federal government, and we estimated a cost of around $17 million in 2026. The reality is there is a significant and continued rise of obesity with compounding impact on diabetes and other medical conditions. According to the NIH, over 85% of people with type 2 are overweight or obese. This is strong and consistent evidence that obesity management can delay the progression from prediabetes to type 2 diabetes, to say nothing of the 198 medical disorders that obesity influences. We recommend comprehensive access to and coverage of person-centered obesity treatment, and as such, strongly encourage a favorable report. Thank you.
Thank you. And you're Monica Bilger.
Yes,
right?
ma'am.
Thank you. Who's next?
Good afternoon, Chairperson, members of the committee. My name is Nikki Massey, and I'm here today as someone who has lived with obesity my entire life. I urge you to support Senate Bill 876 because access to comprehensive obesity treatment should not be dictated by outdated biases, but by evidence-based medical care. Since childhood, I have struggled with my weight. My parents tried to help, diets didn't work. I was bullied in school and felt like a failure because I couldn't achieve a normal weight. In my early 30s, as a mother of 2 young children, I decided to pursue bariatric surgery to regain mobility and energy, but accessing that care was far from simple. I had to find a doctor who even believed in treating obesity, not just telling me to eat less and move more. Insurance created barriers, adding last-minute requirements to delay my care. And while I eventually had my surgery in 2008, my post-operative care was short-lived. After just a few years, I was left to manage my long-term care on my own without guidance or medical support that other chronic conditions receive. Years later, my weight began creeping back, first slowly, then significantly after major medical events, including a bilateral mastectomy. Today, I am left in sort of a medical no man's land. Even weight management specialists struggle to determine how to treat me. Should I be treated as a post-bariatric patient, as someone who has never had surgery? There really is no clear path, and the latest treatments like GLP-1 medications are financially out of reach because insurance refuses to cover them. If this bill passes, people like me will have access to a broader spectrum of treatment instead of being forced into only what insurance deems acceptable. Obesity is a complex disease that requires individualized care. I deserve the best treatment for my body just as every other patient deserves the best for theirs. To put this in perspective, when I had breast cancer, my treatment was clear and compassionate. There was a standardized path, follow-up care for life, and no barriers to the treatment that I needed. But when it came to treating my obesity, a disease that also impacts my long-term health, there was no roadmap, no doctor guiding me, and no commitment to my care. Instead, I faced a lot of stigma, hoops to jump through, and the burden of navigating a broken system on my own.
Thank you, Nikki, for your testimony. Dr. Nima Gankar?
Thank you, Madam Chair. My name is Ashish Nimgankar. I'm one of the gastrointestinal, liver, and obesity medicine specialists at Johns Hopkins. But today, I speak as a physician who has seen too many patients suffer the complications of obesity, not because we lack treatments, but because they can't access the care they need. Obesity is not a lifestyle choice, it's a deadly disease. Yet instead of being treated, it is blamed on willpower, while it silently kills millions. We now have proven life-saving medications like the GLP-1 drugs. They have transformed obesity care. The newer GLP-1-based drugs are more effective than even weight loss surgery, with much lower risk. But the irony is that insurance, Medicaid covers weight loss surgery and not these drugs. And this isn't just about weight loss, it's about survival. In fact, last week I saw a young woman with liver failure who asked me, will I be around to see my kids grow up? Her only hope is a liver transplant, and only 1 in 500 patients can get one. GLP-1s could prevent her from ever needing one, as obesity is the leading cause of liver cirrhosis. And it's not just deaths from liver failure. These drugs cut down heart attack, stroke risk by almost 25% and prevent 1 in every 3 deaths. I have patients trapped in dialysis chairs for hours each week just to stay alive. These drugs can lower the likelihood of requiring dialysis by more than 25%. And here's what's truly remarkable. Many of these benefits begin within the first week of treatment with these drugs. Yet Medicaid patients who are disproportionately affected by obesity and its complications face the greatest barriers to accessing these treatments. They deserve the same access to life-saving care as those with commercial insurance. The passage of this bill is a critical step in closing that gap. Thank you.
Thank you, Doctor. And then Mr. Patel.
Hi. Dear Chair Bidle, Vice Chair Hayes, members of the Senate Finance Committee. I'm Mihir Patel. I'm a primary care physician, obesity medicine specialist at the University of Maryland School of Medicine. My remarks are my personal opinion, not a reflection of the School of Medicine. So I've been doing this for about 8 years. The single best part of my workday is when I get to tell someone that obesity is not their fault. I get to go through the genetics, the microbiome, the physiology, and I get to see people, some people cry, some people breathe a sigh of relief, but everybody feels validated. And then I get to offer solutions. When thinking about solutions and medications, I think about this one patient, number of patients, but this one stands out. 72-year-old female. She had a history of breast cancer, knee replacement. She had sleep apnea. And we were able, through patient assistance programs, to get her anti-obesity therapy. And we were able to completely transform her life. Thoughts of food did not consume her. She was able to transform her diet. And most amazingly, we were able to cure her sleep apnea, where she didn't need a breathing machine at night anymore. And I can't help but think, what if we were able to get to her earlier? What if we treated her earlier, she didn't ever develop sleep apnea in the first place, didn't have a knee replacement, or didn't even develop breast cancer originally. But unfortunately, Maryland Medical Assistance Programs recipients currently lack the coverage for anti-obesity therapy, but they are just as deserving for these life-altering therapies as the individual I mentioned. So I urge you to support Senate Bill 876. Thank you.
Thank you, Doctor. Do I have any questions for this panel? Senator Lamb.
Yeah, thank you, Madam Chair. Thank you to
the sponsor panel, the sponsors for bringing this bill forward. From a perspective as a preventive medicine physician, I think this obviously makes a lot of sense. I think this is something that we had obviously looked at last year as well. And do note that in the letter that the department submitted this year, which was informational, that Medicaid will now cover Wegovy, one of the medications for people who are overweight and also have cardiovascular disease. I think it's really disappointing that we have to wait until someone is actually sick before they can get the medications they need, when we can actually try to address some of their weight issues and obesity up front. And whether that's the stigma or, they cite the costs, I think it's really unfortunate that we have to wait until people get sick before they can get the medications they need. Now, with the cost, from my perspective, I think, one, there's a lot of great inflation here, right? And I think you referenced that in your testimony as well, where, I think they cite 15% of people would require this. That seems wildly high. Number two, the fiscal note doesn't account for the cost savings, right? So that if you have fewer people that have obesity, less likely to get injuries, less likely to need surgeries, whether it's knee replacements, hip replacements, the like, I think that's not taken into account in this fiscal note. So, I guess for this panel, when I looked at this letter too, the department wrote out of the state plan a way for the Medicaid Pharmaceutical Therapeutics Committee. So this is a committee that helps provide recommendations for whether drugs would be covered or not. The department basically exempted these drugs from even being considered by the Pharmacy Therapeutics Committee on whether these should be covered, which seems like the department doesn't even want to have a conversation about whether or not coverage is a good idea for these drugs. What's been your sense in conversations with the department on whether, one, they seem amenable to, more realistically understanding the usage of this, bring the cost down, but also on this Pharmacy and Therapeutics Committee, can we defer to that committee to provide a recommendation on whether this should be covered? Would you as a sponsor be open to that? And have you had any conversations with the department about that?
Yes, Senator, I was not aware of that group that would make the recommendations, and certainly did not hear that these GLP-1s were exempted from that process. So that obviously would be a good place to start as well with that. To say that I was disappointed in the department's position on this is an understatement as well, too. I think the committee last year, flat out said that we want to have a real study on the costs of this. We would certainly like to know also, a better position on the offsets. What would happen if we were able to treat a number of people and not have to go through further expenses, like we said. But, there is information that comes from the Kaiser Family Foundation about anti-obesity medication, Medicaid utilizations, and it goes through 12 different states: Michigan 1.95, Kansas 2.15, Delaware 1.4, Pennsylvania 1.5, Hawaii 0.1, Minnesota 3.16, Mississippi 0.78, New Hampshire 1.03, Virginia 0.92, California 1.13, Rhode Island 1.33, Wisconsin 2.88. Far different numbers than we've seen from the Department of Health. And so,
and just to be clear, our grade inflation that they're citing is like 15%.
15%, correct, is what they've said here. So, it is very unfortunate. And also you read a statement from them in their letter that says Medicaid covers bariatric surgery for participants who meet certain clinical criteria. Intensive behavioral therapy is also covered under existing benefits. Like, those are the only two options. And that's what's disappointing when our own Department of Health cannot see the value of this, and goes to what we were told again from bariatric surgery is a much more invasive surgery, and then just simply the IBTs that we are talking about is why don't you just eat less and exercise more. Again, I don't think that's where our Department of Health should be. We've seen proven benefits over doing this in many other states. There is conversation at the end about in November that the Biden administration had talked about this being potentially covered. We're certainly waiting to hear if we see that through the Trump administration as well. But that doesn't mean that we can't follow in line with a number of the other states that have gone forward and covered these types of drugs.
Right. Yeah, agree with that. And, I think it is disappointing that if the department doesn't want to do it, be upfront about it. It seems like they're really just inflating the numbers here in a way to kill the bill, to cite a huge cost. But it's also penny wise, pound foolish when, we're maybe saving some money supposedly on the front end, but in the overall scheme of things, we're probably spending more by declining to cover this for obesity purposes. Last question, I guess, citing the part that you referenced there at the end, and maybe this is one that the upcoming panel can also address as well, is the letter from the department, I guess warns that the feds may not match the state if we decide to proceed with this. I guess the question is, have we seen how other states have handled this? Has there been any, input or feedback on how other states have had to address this, particularly if it's decided that, the feds won't match the cost of this? It's hard to know, I guess, in this instance, because, it's hard to know, what's happening 30 miles from here. But, I think that feedback would be helpful if we have any information from other states. And again, maybe something for the other panel to be able to address too, or to come back to us with.
I think at this juncture, I think at this juncture, sir, there is still the federal match, and so that hasn't been fully explored as to what will happen. No one knows, and then the predictability of the future. So, but certainly I think that there is exploration at this time to see where the things stand. And again, appreciate your time in this space, and we can continue to provide additional information as we receive it, as we're working closely at the 14 other states that are covering this through Medicaid and are, looking at their utilization data and rates and all of those things to ensure that they're providing the most up-to-date information possible. And so we're carefully examining that as well.
Right. And just to point out that you said 14 other states cover this, they have not gone bankrupt.
Correct.
All right, thank you.
We're already going bankrupt. Senator Mounts.
Not from being proactive.
And I have a quick question for Dr. I'm not sure if I've got the names correct. With two doctors, but the weight loss drugs have been stigmatized. They're vanity drugs. They're you've seen so many things about them. There's a lot of hearsay about them, rumors, things like that. Can you speak to the efficacy of these drugs? How they work. I've seen them demonized as dangerous and unhealthy and all these other things. And I also know from talking to medical professionals how well they work, and how reliable they are. And can you talk about that, and not just the efficacy of the drugs, but how it impacts those patients that need the drugs?
Yeah. So like the patient I mentioned, there's a number of ways they work. We know appetite, hunger, all the signals are converge at the brain, and these medications work on a different levels of the body. But the best way I think we use them is to help people change how they're eating and and change their behaviors. We talk about diet and exercise, and that's still, some people say that you could say that's foundational. But the way I use these is I think when I started using these, I found that people were able to change their lifestyle. And along with lifestyle changes, they were able to lose the weight. I don't think the medicine is doing it on its own, but I think it's helping people get to a place where they know they need to get to, and they just need the help to do that. As far as addressing the safety of it, we do screen patients for some of the side effects and some of the long-term side effects from these medications. But overall, they're pretty safe. And I think if you use them in the right way, you monitor them, you have follow-up appointments, and you kind of continue to check in with patients and monitor them, they're pretty safe. And I think when you think about safety, you have to think about what are the long-term consequences of obesity versus these medications. And in the long run, I mean, you know, we talked about all the medical conditions, the heart disease, the cancers, the knee replacements. And I think though that's we have to think about that as a side effect of not treating this disease. So there's two ways I look at safety. I think if you use them properly, they're safe. And I think what are the side effects of not treating?
Thank you.
I don't know if you want to jump in.
Yeah, I would certainly like to add a few comments here. It's important to recognize that GLP-1 drugs have been around for 20 years. They were first approved back in 2004, 2005 for type 2 diabetes. So we have extensive safety track record on these drugs. That's first thing. The second thing is, as I mentioned, bariatric surgery, weight loss surgery, you can lose anywhere from 20 to 30%. With the more effective GLP-1 drugs, you can lose upwards of 30% weight loss. But it's not all within the first 2 months. It takes a while. But these are extremely effective at a fraction of the risk that bariatric surgery entails on a patient.
Yeah, and what are the critical conditions that they cure? I know it's stroke, heart attack. Can you just list them off?
Yeah, now there have been large studies published in very reputable journals which have shown that GLP-1 drugs cut down the risk of heart failure, cardiovascular mortality, chronic kidney disease, which results in dialysis, osteoarthritis, and as well as fatty liver and inflammation of the liver leading to cirrhosis. And that's just a fraction of the many other studies that are ongoing, showing effects on pretty much every organ in the body.
Thank you.
May I just really quickly, do we have time?
Can we just move on to another question, please?
I'm only allowed one question.
Oh,
one witness,
well, no,
or I get in
add
big
on to
trouble.
what he said.
Oh,
Oh, no, never mind that, sorry.
Senator Ellis.
Yes, thank you, Madam Chair. And, thank you, Senator Hershey, for this bill. So everything we do, we look at the fiscal note. I was looking at, I was thinking thousands, like 225,000. I looked again and said million. And so forgive me for my loopiness this morning, this afternoon. So looking at the fiscal note with the current climate, I don't know if you thought about the cost before you put the bill in. A lot of times we put the bill in and we just look at the cost later. It was one thing they were instructed, if you really want to spend this money, where would you get it from? So how would you answer that question? I mean, of course, you put the bill in, you think it's a worthwhile investment. So how would you pay for it?
I guess you can't answer that one. Do you want to?
No, it's you,
I'm
Senator.
just teasing.
You trying to run from it?
No, Senator. But we're trying to get one more response from Nikki there. To address the fiscal note, as we stated before, if you remember last year, we had very similar legislation, and we decided to make it a study bill. And the report that Department of Health provided is in your package of information. But again, and to echo some of the comments that Senator Lamb made as well too, we think that they have greatly overestimated the utilization rates. And as I said, there are 14 other states, I read off all of those, that are much lower. I think only one is over 3%, just barely over 3%. And yet the Department of Health in Maryland has come up with a number of over 15%. So even
I'm sorry, if we 15% what?
What's that?
I'm not sure what these numbers you're throwing out is.
The utilization rate, so how many?
What does that mean, utilization
That would
rate?
be of the eligible Medicaid patients, what percent of them would utilize these drugs?
Okay.
These drugs. And so the reason that we're seeing the fiscal note so high is, again, this is based on an estimate, but the Department of Health has estimated utilization to be at 15%. And again, we would say, based on evidence of the 14 other states that have gone forward with legislation like this, we would believe it to be 3% at the highest, and actually a chance to be much lower than that.
Yeah. So even if it's at 3%, which would probably cut in
I think the
a fourth,
number was
yeah,
maybe at 3%, maybe $20 million.
$20 million. Yeah. Even still, I mean, how would you suggest?
Because the other thing
for
that
it.
the fiscal note doesn't describe and account for is what we call the offsets. So the amount of, and the cost of treating disease and illnesses that are related to being obesity. And so what you'd have to do is take both of those numbers. If we spent $20 million, for instance, to allow patients to use the GLP-1s, what did we save by fewer knee replacements, fewer dialysis, fewer treatments for all types of cardiovascular diseases and everything else, emergency room visits, workplace productivity? You'd have to take all of those and say, are we saving money here? And then how do you square that away with what the costs are?
So
Like,
you-
as any business owner might do
So,
if they were looking at
yeah.
something.
So you
this
feel
type of
comfortable,
decision.
you feel comfortable spending this money,
I think
whether
there's-
it's 20 million or 250
Yeah,
million?
Senator, I think there's
year.
evidence from the 14 states that have done this already that they are seeing dramatic increases, decreases, or increases in the amount of saving, decreases in the cost of caring for those other types of ailments.
Okay, great, thank you.
Thank you.
Thank you, Senator.
Thank you.
Senator Hershey, has there been any response about the cost of bariatric surgery and the follow-up compared to medication? I mean, I've got to think that's more expensive with a higher risk.
You know, Madam Chair, I did not take that step to see what the actual costs were there. I would agree with you that, one, not only are they higher costs, and Nikki, you might know how that ended up working, but not only higher costs, but certainly a much more invasive surgery, and opportunities for a lot more things to go wrong. It just seems, again, that's what's frustrating about their comments, that, you know, in their mind, Maryland's Department of Health says, well, why don't you look at bariatric surgery and the IBTs and, you know, just eat less and exercise more and you'll be fine, which is a very unfortunate approach from hearing from our Department of Health.
Thank you, Senator. I don't see any other questions for this panel. Thank you for your testimony. We have two more favorables and one favorable amendment that I'm going to bring up together. Jeannie Blankenship is favorable, William Kress, and Barbara Hofstein is favorable with amendment. So if you all come to the table, please. We only have one person?
Yes, I don't see Jeannie Blankenship. I know her.
You're Jean Blankenship?
No, I'm Barbara Hofstein.
Okay. Is Jean Blankenship here or William Kress? Well, Barbara, I think it's all you. Thank you.
Thank you, Senator Bidel and the members of the Finance Committee. My name is Barbara Hofstein. I'm a registered licensed dietitian, and I am here today on behalf of the Maryland Academy of Nutrition and Dietetics, MAND, which represents 1,900 registered dietitian nutritionists in the state of Maryland. We would like to support SB 0876, but with an amendment including medical nutrition therapy. We all heard about the many chronic diseases related to obesity. Currently, SB 876 includes insurance coverage for intensive behavioral therapy, bariatric surgery, and weight loss medications, all valuable tools. However, comprehensive nutrition is missing. While IBT includes some nutrition guidance as part of its structured behavioral framework, it is not designed to provide the comprehensive individual clinical nutrition intervention that medical nutrition, MNT, does. It is an evidence-based, personalized approach to nutrition for the prevention, management, and treatment of medical conditions, including obesity, by trained dietitians. Research shows that individualized interventions are a critical component of obesity care. A review of 62 randomized controlled trials found that patients receiving RDN-led education saw greater weight loss, reduced blood pressure, and improve quality of life compared to those who did not get it. Furthermore, MNT can uniquely address the effects of the GLP therapies and they can target dietary strategies to help patients tolerate medications and stay on treatment longer. RDNs can reduce the nausea and improve digestive comfort. So with this amendment, Maryland can improve patient outcomes, improve sustainable long-term solutions to those managing obesity, and as we heard, decrease the healthcare costs.
Thank you. Do I have any questions for this witness? I don't see any questions. Thank you for your testimony.
Thank you.
We have two people virtually. First, we're going to hear from Sheila Maggie. Oh, I'm sorry. Rhonda Carrington's first? Okay, I'm sorry. Rhonda Carrington, will you unmute and give us your testimony?
Hello and good afternoon. Thank you for allowing me to speak today in reference to the medications for weight loss that could possibly help my grandson and other people that has health challenges. My grandson, that's 22, has health issues and severe sleep apnea. I think if you pass this law to help other people and to help him as well, this would give people a better life.
Rhonda, is that your entire testimony?
Yes.
Thank you very much for your testimony.
Okay, thank you.
Sheila Maggie?
Yes, hello. Honorable Chair, Vice Chair, and members of the Finance Committee, thank you for the opportunity to speak to you today in support of SB 876. My name is Dr. Sheila Maggie. I am the Director of Pediatric Endocrinology at Diabetes at Johns Hopkins Children's Center in Baltimore. However, my remarks today are my personal professional opinion, and I am not speaking on behalf of my institution. My area of clinical and research expertise is pediatric obesity, prediabetes, and youth onset type 2 diabetes. With increased childhood obesity, we're seeing conditions that we previously saw almost exclusively in adults, such as type 2 diabetes, occurring in children as young as 8 to 10 years old. Throughout the last 20 years, I've cared for children with obesity, and the first-line treatment is always working to increase physical activity and improve nutrition. However, in many cases, this is not enough to prevent progression of weight gain. Obesity is a disease that has a strong genetic component, and lifestyle changes alone are often not enough. However, in the last 5 years, have seen the emergence of obesity medications that are truly game changers. In fact, for cases in which lifestyle modification is not successful, the American Academy of Pediatrics recommends offering treatment with pharmacotherapy as an adjunct to exercise and nutrition. And there are medications that have been FDA approved to treat obesity in youth 12 and older. But for my patients with obesity on Medicaid, even though they're clinically recommended treatments that are FDA approved, their insurance will not cover them. In fact, I have 12-year-old patients with obesity who have developed prediabetes and have abnormal blood sugars, but I have to wait until they actually develop diabetes to treat them instead of preventing diabetes in the first place. This makes no sense. Compare this to a child with commercial insurance who's able to start on obesity medication, lose weight, and never develop diabetes. This creates significant health disparities. We need to be able to treat with obesity medications when indicated to prevent medical complications in our vulnerable youth. Thank you for your time and attention.
Thank you for your testimony. I don't see any questions, but thank you very much. And that ends the hearing on Senate Bill 876. And now we're going to go to Senate Bill 748, Senator Kramer. And Senator Kramer is bringing us Alzheimer's disease and related dementias, information on prevalence and treatment. And he has a panel of Megan Peters, Dr. Halima Amjad, and Patricia Joraman. Thank you.
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. Ben Kramer to introduce Senate Bill 748. Colleagues, Alzheimer's disease and related dementias are among the most pressing of our public health challenges, and as the aging population grows, so does the prevalence of these neurodegenerative diseases. While national data on Alzheimer's and dementia provide a broad picture of the issue, geographic specific data, particularly at the state and local level, is crucial for understanding the unique needs of different communities. In Maryland, collecting and analyzing state-specific data on Alzheimer's and related dementias is essential for developing targeted public health strategies. Improving resource allocation, supporting caregivers is all part of what we need to do with data. Furthermore, ensuring that Maryland residents have access to the latest information on Alzheimer's research and potential treatments is vital for advancing care, improving quality of life, and fostering innovation. Alzheimer's and dementia do not impact all communities equally. Geographic-specific data allow researchers and policymakers to identify regional disparities in the prevalence, diagnosis rates, and access to care. Factors such as socioeconomic status, racial and ethnic demographics, healthcare infrastructure, and environmental conditions all influence the risk and progression of these diseases. In Maryland, for example, urban areas like Baltimore may face very different challenges than rural counties on the Eastern Shore, where access to specialized care is more limited. Without localized data, it is difficult to implement effective interventions that address the unique needs of each community. State-specific data can help policymakers allocate resources more efficiently. Maryland's government and healthcare providers need detailed information on Alzheimer's prevalence to determine where to establish memory care centers, allocate funding for caregiver support programs, and invest in early detection initiatives. Family members and caregivers bear much of the responsibility for caring for individuals with dementia. In Maryland, caregivers in different regions may have varying levels of access to support, services such as respite care, adult day programs, and home health aides. By collecting data on where caregiver burdens are highest, state agencies and nonprofit organizations can design and fund support programs tailored to the needs of Maryland's residents. Alzheimer's disease and related dementias pose a significant challenge to Maryland's aging population, and ensuring that Maryland residents and caregivers have access to the latest research and potential treatments is crucial for improving early detection, treatment options, and fostering participation in clinical trials. By prioritizing both localized data collection and public education and awareness on Alzheimer's research, Maryland can lead the way in combating this devastating disease and improving the lives of those affected by it. And the bill before you, colleagues, does the following. With regard to educating healthcare providers, it extends current law to include treatments approved by the Food and Drug Administration for Alzheimer's disease and related dementias. And it also provides the department, in collaboration with the state designated health information exchange, shall establish and maintain a publicly accessible website that includes in a downloadable format the following information: the prevalence of Alzheimer's disease and related dementias in the state, the hospitalization rate related to Alzheimer's disease and related dementias, and to the extent possible, the prevalence and hospitalization rate of Alzheimer's based on age, including the age of diagnosis, sex, race, ethnicity, and the number of cases by county. So the goal here is to try to get as much data as we can so that we are well informed and know how best to utilize existing resources in combating Alzheimer's and dementia. So with that, I'm happy to turn it over to the panel.
Thank you. Who'd like to go first? Megan Peterson.
Good afternoon, Chair, Vice Chair, members of the committee. For the record, my name is Megan Peters, Director of Government Affairs for the Alzheimer's Association, here in strong support of Senate Bill 748. I'd like to thank Senator Kramer for sponsoring this important legislation and just wanted to take a moment to highlight a few key items about this bill. First, as the Senator mentioned, we need the state-specific data. Without it, we are limiting our understanding of the burden and scope of dementia in Maryland. And this data will help all sectors involved that work in the dementia space. And this can come in the shape of more effective resource and funding allocation because organizations have data to make decisions and understand the number of people impacted in their local communities. It can strengthen our public health programs through more accurate data to help in the planning process. And it can improve our future research findings by having localized data to inform trends, identify risk factors, and more. I'll also add that this data reporting aligns with and is a recommendation of Goal 5 of our state plan to address Alzheimer's and dementia. Secondly, we are in a new era of treatment that is bringing a lot of hope to families, and this bill ensures that Marylanders and their healthcare providers are aware of this FDA-approved treatments for Alzheimer's and dementia. And lastly, I want to acknowledge the fiscal note. There is a very minimal impact, but in comparison to the growing impact on Maryland Medicaid spending for people of people with Alzheimer's, which was over $1.2 billion in 2020, this bill has the opportunity to drive long-term savings. Additionally, the association has connected with CRISP, and we can partner with MDH to drive the costs lower because CRISP can readily collect and pull this data with their existing staff. Dementia is a growing public health crisis, and we need to take a comprehensive approach to addressing it, and I urge the committee to vote favorably on Senate Bill 748. Thank you.
Good afternoon. My name is Patricia Gerolamo-Selko from District 42A, Baltimore County. I urge you to support SB 748. This bill is important to me because it will ensure that dementia-related public health outreach educates Marylanders on Alzheimer's treatments. I believe this will encourage earlier diagnosis, allow individuals to receive treatment sooner, and promote healthier lifestyles. My mother silently struggled for years with memory loss. She was terrified of Alzheimer's and never sought help after witnessing her own mother endure 8 years battling this disease. Unfortunately, she wasn't alone. Many people fear Alzheimer's more than cancer. I often wonder if we could have had more time with her at home, if there had been more public awareness, or if the doctors were better equipped to talk to patients about their symptoms and educate caregivers. During the same time, my husband kept telling me there was something off about his memory. Over the course of 6 months, we went to the primary care doctor 3 times. The first 2 appointments, he was prescribed anti-anxiety medication and was labeled anxious aging. In the second visit, the doctor directly told him, "You don't have dementia," even without conducting a cognitive assessment. After the third visit, we pushed harder and finally received a referral to a memory clinic. However, that took 6 months to get an appointment. Over the next 5 months, we underwent multiple diagnostic tests and he was diagnosed with mild cognitive impairment due to Alzheimer's. Those 5 months were terrifying and increased his anxiety, which in turn worsened his symptoms. He started an FDA-approved treatment, Leqembi, and we've made some lifestyle changes, and we've seen some improvement. The current healthcare system creates anxiety, which worsens the disease. It doesn't have to be this way. If the healthcare community wants the public to seek treatment early and not ignore symptoms, more support and information for those navigating this process is needed. Thank you for your time.
Good afternoon. My name is Dr. Halima Amjad. I'm a geriatrician, dementia specialist, and researcher at Johns Hopkins. I'm also the daughter of a beloved father who had young onset frontotemporal dementia. I'm the current chair of the Maryland Virginia I. Jones Alzheimer's Disease and Related Dementias Council. I'm here on behalf of the council to support Senate Bill 748. In Maryland, work to advance dementia research and care is of utmost importance. Maryland is estimated to have the highest prevalence of dementia among older adults, with Baltimore City and Prince George's County among the top cities and counties in the nation. Our council works closely with the Department of Health and other partners to improve the lives of over 120,000 Marylanders living with dementia and their families. This bill aligns with the goals of the 2022 to 26 Maryland State Plan to address dementia and advances our statewide efforts in two key ways. First, the bill expands public health outreach to include healthcare provider education on early detection, diagnosis, and treatments available for Alzheimer's and dementias. Most healthcare providers have limited knowledge of these topics that are rapidly evolving. This bill helps fill this gap. Second, the bill establishes a statewide dementia database. While Maryland may have a high prevalence of dementia, we also have a unique data resource in our CRISP State Health Information Exchange, alongside rich research, public health, and health system capacity. Accessible data on true dementia prevalence, not just estimates, and hospitalizations, a common but particularly difficult event in dementia, is crucial. These data will allow researchers, health systems, organizations, and local and state agencies to better understand and serve this vulnerable population. Our council looks forward to your favorable position on Senate Bill 748. Thank you.
I don't see any questions. Thank you very much. We have one virtual favor with amendment, Liz Zogby. Liz, you want to unmute? There you go.
Good afternoon, Chair, Vice Chair, and members of the Senate Finance Committee. My name is Liz Zogby from the Maryland Down Syndrome Advocacy Coalition. MDAC is a coalition of organizations, individuals with Down syndrome, and family members who advocate for improved quality of life for Marylanders with Down syndrome. As the leading cause of death of adults with Down syndrome, Alzheimer's disease is an urgent medical concern for our community, and we therefore have a particular interest in this bill. By age 40, the brains of almost all individuals with Down syndrome have significant levels of amyloid plaques, one of the hallmarks of Alzheimer's disease. This is because chromosome 21, which is triplicated in individuals with Down syndrome, is the site of the gene that produces amyloid protein, which make up amyloid beta plaques. Because people with Down syndrome have an extra copy of this gene, they have an extra amount of amyloid protein and develop Alzheimer's disease at a high rate and at a younger age than the general population. It's notable, however, that despite the presence of these brain changes, it is estimated that only about 50% of people with Down syndrome actually develop Alzheimer's symptoms. The question of why this disconnect exists between brain changes and disease progression in people with Down syndrome is a promising path for treatments and a cure for all. For these reasons, it's important to our Down syndrome community that the prevalence and hospitalization rate of Alzheimer's disease and related dementias in Maryland be tracked and that the data be disaggregated. MDAC suggests an amendment that the co-occurrence of Down syndrome be added as a data element. This information could lead to additional opportunities for research, treatment, and targeted policy or programs to meet the needs of this population. MDAC appreciates the introduction of this important bill and strongly supports its passage while suggesting this amendment to highlight the unique connection between Alzheimer's disease and Down syndrome. Thank you.
Thank you for that testimony. Any questions? No? No additional questions. Thank you very much.
Thank you.
That ends the hearing on Senate Bill 748. We're going to skip a bill and go to Senate Bill 940, Senator Guile, Public Health, Maryland Interested Parties Advisory Group Establishment. And Senator Guile has a panel, Allison Yunda, Monique Lynch, David Rodwin, Megan Peters, and Ryan Moran, who's favored with amendment, but you have them on your panel. Correct, Senator? Okay.
Just wait. Secretary Florian. Hi. Hi. Good. How are you? Good to see you too. Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. Senate Bill 920 is about making sure that policymakers hear the voices and experiences of those most affected by Maryland's Medicaid-funded home care policies. All of us know someone who has depended on home care at one time or another so that they can remain in their home and not go into a nursing facility. The need for such home care services is rising as Marylanders live longer. And as the need for more home care increases, so does the need for more workers to provide that home care. Unfortunately, there are not nearly enough workers to meet the needs of Maryland's older adults and people with disabilities. Maryland ranks 49th out of 50 states, the second worst in the difference between home care workers' actual wages and a living wage, according to a recent study by the Economic Policy Institute and New America. Most home care in our state is funded by Medicaid. Because of that, Medicaid policies, including reimbursement rates, determine whether home care jobs are good enough to attract and retain the home care workforce that Marylanders depend on. Recognizing that connection, the prior administration, Center for Medicare and Medicaid Services, finalized a rule called Ensuring Access to Medicaid Services. The rule ensures that states administer their Medicaid home care programs effectively, including by establishing an interested parties advisory group. The interested parties advisory groups are comprised of people affected by Medicaid-funded home care that gathers and advises the state on Medicaid home care policies, including reimbursement rates, with the goal of ensuring that all eligible Marylanders have access to the care they need and deserve. Senate Bill 920 implements the requirements of the federal rule, builds on it, and implements it ahead of schedule. It ensures that policymakers hear the voices of those who actually do the home care work that so many Marylanders depend on, and of those who depend on their care. Yesterday afternoon, I was made aware that proponents of the bill and MDH have agreed on final amendments to the bill, which I requested from DLS. My team will submit those to the committee as soon as we receive them. As for the fiscal note, MDH has confirmed that the aforementioned amendments will zero out the expected costs of the bill. And for these reasons, I respectfully request a favorable report on Senate Bill 920. Thank you.
Thank you, Senator. Who would like to go next?
Hi, dear Chair Vital, Vice Chair Hayes, and members of the committee. My name is Allison Yunda, and I'm here on behalf of the National Domestic Workers Alliance, or NDWA, to submit testimony in support of SB 920 to establish the Maryland Interest Parties Advisory Group. NDWA is the leading voice for the estimated 2.2 million domestic workers who work as direct care workers, nannies, and house cleaners. And while NDWA is a national organization, our DMV chapter is a locally operated membership-based organization covering the geographical area of Washington, D.C., Maryland, and Virginia. SB 920 establishes the Interest Parties Advisory Group, or IPAG, within the Maryland Department of Health as mandated by federal law. This group will include representatives from direct care workers and consumers and will provide key recommendations to the state on improving provider payment rates for home care services, focusing on the wages and working conditions of direct care workers. The demand for home health and personal care aides will continue to rise. In Maryland, over 127,000 residents need help with daily activities, and 15% of those over 65 report difficulties with tasks like bathing and dressing. The state's older adult population is only continuing to grow. Despite the increased demand and essential nature of home care, the caregiving work of personal care aides is still not valued. Workers receive extremely low pay, few benefits, and enjoy limited protections in Maryland. In Maryland, there are approximately 51,200 direct care workers, with their median annual income being only $28,124. SB 920 provides a framework and mandate to the Maryland Department of Health to establish a robust IPAC that allows for meaningful participation of the direct care workforce, helps ensure that Maryland takes action to set Medicaid rates high, enough for sufficient wages, analyzes other issues facing the workforce, and gives workers a voice to provide strong recommendations to policymakers on how how these wages can raise rates in order to improve working standards. For these reasons, the National Domestic Workers Alliance fully supports SB 920, the Interest Parties Advisory Group of 2025.
Good afternoon, Chair, Vice Chair, members of the committee. For the record, Megan Peters with the Alzheimer's Association, here in support of Senate Bill 920. For many people living with dementia, there will come a time when they need more than just the care from an informal caregiver, and many of the times this comes from home and community-based services. We know these services are vital to keeping people living in the community as long as possible. Senate Bill 920 is an important bill that will codify and add to the federally required Interested Parties Advisory Group, which aims to ensure access to these home and community-based services, as well as assess direct care workforce adequacy. Today, 1 in 3 people using home health services has Alzheimer's or dementia, and the largest segment of that workforce supporting these individuals is our direct care workforce. We know that the demand for these workers is only going to increase as our population ages and more people develop dementia. We need to support these workers with better wages and supports. So SB 920 will help this by prioritizing the perspective of workers as well as consumers who use these services, such as people living with dementia and their caregivers, on recommendations for Medicaid payment rates. Bringing in these perspectives is critical to making informed policy decisions and will help Maryland recruit and retain these critical workers in the years ahead. The Alzheimer's Association urges a favorable report for SB 920. Thank you.
Thank you, Megan. David, you want to go next?
Good afternoon, Chair Beidel, Vice Chair Hayes, members of the committee. My name is David Rodwin. I'm with the public interest law firm of Murphy Anderson, PLLC, and here on behalf of the National Domestic Workers Alliance in support of this bill. And we're very grateful to Senator Guile for sponsoring it. I think this bill is about getting Maryland ahead of the curve in implementing federal requirements that already exist under this new CMS rule, which remains active. It gets some meat on the bones of that sort of bare bones federal rule. I am so happy to reiterate that Senator Giles' news that we have agreement here with MDH on the amendments. I also want to note that the federal rule does not require employer participation on the Interested Parties Advisory Group. As initially drafted, we had a spot for employers, and under the amendments, we now have 2. So there is, in this agreed upon amendment, 2 spots for employer provider voices here, as well as those who provide the care, direct care workers, and consumers, those who receive the care, and those who represent them. So very happy to be here today and ask for the committee's support of this important bill. Thank you.
Dr. Moran.
Yes, thank you, Chair Beidel, Vice Chair Hayes. I'm jealous of your Cheetos as you eat those. For the record, Acting Secretary Ryan Moran. Happy to be here and appreciate and thank Senator Guile for sponsoring this bill. Just to give you a little bit of context, this bill, from a federal requirements perspective, the Interested Parties Advisory Group is a body that's created for state Medicaid programs to have a group of individuals that's working with the state to monitor the payment adequacy related to the rates. And it does provide flexibility, if you will, of the voices that are provided in terms of overseeing that and advising, ensuring rate sufficiency specifically within our home and community-based services programs. I will also just mention that the amendments that we have worked on together include the scope of this particular bill, ensuring that it aligns with the federal requirements in that regard. Second, on membership, I appreciate David's mention in terms of the work here of direct care workers, but also provider associations. We've also included the Department of Labor and their commitment to join MDH on this work group as well. The ability for this group to meet annually, and then as good transparency, publishing the work that comes out of this particular group on our website on an annual basis as well. So with that and those particular amendments, I'm looking forward to working with the committee and request a favorable report.
Thank you very much. Senator Mount.
Thanks. Just a quick question for the Secretary. Acting Secretary, thanks for being here. This just increases the rates, correct?
This actually does not do anything related to Medicaid rates. But what this body is supposed to be and designed to do is to advise on that. And so you can think of this group as a way where we would bring data related to how rates could be set that they would have input in terms of advising the department on. And so that's why it was really important to think about this from multiple different stakeholders that are involved in the rate setting, including direct care workers, but also then the direct providers themselves as well.
Oh, great. Thank you.
Thank you, Senator. I think almost all our other senators are out at other meetings, but thank you all for your testimony.
Thank you.
That ends this panel, and we're going to bring up another panel of favorables. Sandy Balin, Melissa Carter, Jaleesa Jabi, Lorraine Arakat, Paul Ellington, and Sam Williamson. So if you're here, please come to the table. Who'd like to begin? Lorraine, you want to begin for us? Sure. Thank you.
Good afternoon, Chair Beidel and members of the committee. My name is Lorraine Arikat, Senior Policy Analyst with 1199 SEIU, United Healthcare Workers East. We're the largest healthcare workers union in the nation, representing 10,000 healthcare workers in long-term care facilities and hospitals across Maryland. 1199 strongly supports SB 920, which will ensure that home care workers, those relying on home care services, and other relevant stakeholders will have a seat at the table when evaluating Medicaid provider rates that impact access to care and job quality. 1199 represents healthcare workers across the care continuum in long-term care, hospitals, and clinics. And we know how our broken long-term care system impacts our state's unique total cost of care healthcare model and our already burdened emergency rooms. Ensuring we have the care force in Maryland to let residents age safely in their homes will positively impact the entire care system. Despite the increasing demand for home and community-based services and the essential nature of home care, the caregiving work of personal care aides is still not valued. Workers receive extremely low pay, few benefits, and enjoy limited protections. Home care workers are still earning as low as $15 per hour with very little job security. The majority of home care workers are Black and women of color. 1199 SEIU believes that those closest to the problem are often closest to the solution. Thus, it is imperative to ensure direct care worker voices lead the state to adequate Medicaid rates that can increase wages, benefits, improve retention, and ensure the state has the workforce to deliver high-quality care to our state's most vulnerable. IPAG is one of the requirements under the 2024 CMS-issued federal rule. The federal rule aims to bolster the workforce to improve quality of care in HCBS services. This bill is especially important now because cuts to Medicaid and changes in immigration policy under the new federal administration may exacerbate provider shortages and reduce payment rates for home care workers. For those reasons, 1199 urges a favorable report on SB 920.
Thank you, Lorraine. Who'd like to go next?
Good afternoon, Chair Beidel, Vice Chair Hayes, and members of the committee. My name is Sam Williamson. I'm an attorney with the Public Justice Center, and I'm here in support of SB 920 with sponsor amendments. This bill is an important step towards improving wages for our direct care workforce. Medicaid-funded workers typically only earn $14,600 per year when working on the Eastern Shore and $28,000 per year in the Capital Region. These wages are significantly behind wages for jobs with similar or lower entry-level requirements, lagging $2.28 per hour behind those comparable or easier to obtain jobs. Low compensation is the #1 reason that Maryland is struggling to retain its direct care workforce. And without enough workers, consumers are struggling to get the support that they need. Our Medicaid reimbursement rates are currently too low, and only a portion of those rates actually translate to wages for the workers. By creating an advisory group that is informed by worker and consumer experiences, we can put Maryland in a better position to attract and retain these key workers. For these reasons, the Public Justice Center urges a favorable report on SB 920. Thank you.
Thank you. Sam, I'll wait till the end. Let's go next.
Greetings to the chair, vice chair, and committee. My name is Melissa Carter, and I'm a member of the National Domestic Workers Alliance and I've been a direct care worker for over 24 years. What's kept me in the field is a deep love for seniors and a desire to make a real difference in their lives. And I've worked across various care systems. I've seen the difference that proper care at home care can make. And I used to have a patient who suffered from bipolar disorder and manic depression. She didn't want to bathe or take care of herself. And when I first met her, she struggled to find motivation. But I took care of her, and I slowly saw her regain some confidence and independence, and she also stopped smoking. While the work is rewarding, it is very rewarding, it is also tiresome. The pay is not enough, especially with Medicaid-funded agencies. And if we get sick, we either stay home sick to protect our patients or go to work sick and risk getting our patients sick. I don't ever want to put my patients at risk. By calling off means losing our pay, which is tough. I believe all my patients deserve quality care regardless of their financial situation. Higher wages would allow me to have more stability without needing multiple jobs. It would mean I would be able to buy a home instead of renting my apartment. But more importantly, better wages would lead to better care for our patients. Fair pay for the work is the first step to being recognized for the essential work that we do. Helping them to go to the bathroom, helping to bathe, helps families have peace of mind to go on about their daily work. But the reality is that many care workers are leaving the field because the pay just isn't enough. For things to change, we need your support to represent the changes we deserve. For these reasons, I urge the committee to vote in favor of SB 920, the Interest Parties Advisory Group, so home care workers have a voice in the decisions and Medicaid rates that impact us. Thank you.
Thank you. Next.
Good afternoon, Madam Chair and committee members, and thank you for the opportunity to speak today in support of Senate Bill 0920. My name is Sandy Ballin, and I'm a staff attorney at Disability Rights Maryland. DRM is the federally designated protection and advocacy agency in Maryland, mandated by federal law to advance the civil rights of people with disabilities. The development of home and community-based services served as a critical turning point in ensuring that individuals with disabilities have a choice in where they receive their care. DRM clients often rely on direct care workers to provide them with essential care and assistance within the comfort of their own home. But the concerns of the direct care workers are commonly ignored, leading many to leave the workforce for better conditions and creating a shortage of direct care workers. Such a barrier makes it difficult for individuals with disabilities to access the care that they need to not only thrive within the community, but also just survive. SB 0920 will ensure that this barrier to accessing quality care in Maryland is addressed and resolved. With a more stable direct care workforce, consumers who rely so heavily on these workers can have access to the quality care that they're entitled to. The ability to access such necessary and quality health care without barriers is essential to ensuring that all individuals can live the life that they want and deserve. Unfortunately, the various barriers within the healthcare system prevent individuals with disabilities from doing so. But Senate Bill 0920 can ensure that Maryland is a part of the solution to breaking down those barriers and can help to create a future that allows people with disabilities to feel respected and equal within society. For these very reasons, Disability Rights Maryland strongly supports Senate Bill 0920 and urges a favorable report. Thank you.
Thank you. My name is Paul Ellington. I'm here on behalf of For All Seasons, which is a behavioral health service on the Midshore, and they're the only rape crisis center, state-directed rape crisis center on the Eastern Shore, 5 counties as well. You've heard from a lot of advocates, some practitioners. What we do is we provide services based on, and it's not whether you have insurance or not, that will take you, and there's no real weight given that we have telehealth access. But we see the importance of the direct care workforce providing stability for many behavioral health patients. It gives them the opportunity to live their best life and to have someone so they don't feel isolated and they don't miss their appointments and things like that. And we also support addressing the shortages in Medicaid funding. Where Senator Kramer and I are with the Leisure World and places like that, we see many of these direct care workers, but it shouldn't be the domain of those simply of means. And we believe that this bill helps at least look at that and help close some of the gaps. So we would simply ask for a favorable report on Senate Bill 920, and thank you for your time.
Thank you. I had one more favorable person that maybe, I'm just double checking, Jaleesa Jabi? No, not here. Thank you. Sam, I have a question. You said the pay on the Eastern Shore was like $15,000 a year. That's not full time.
I imagine that many of these workers I've heard many workers say that they struggle to get full hours, and so that is part of it. Some people are also not being paid minimum wage in contravention of the law, so I think it's probably a combination of factors.
Right. I was doing the calculation on the $15 an hour times 2080, and it's over $31,000. That's why I was asking, was it part-time?
Yeah, the data also is from 2023, so it's a couple of years at this point.
Thank you, Sam. Thank you all for your service. I know it's hard work, and I appreciate that. Do I have any other questions for this panel? Seeing no questions, we have one unfavorable. Dana Kaufman.
Good afternoon, Madam Chair, members of the committee. For the record, I'm Dana Kaufman. I'm here on behalf of the Maryland National Capital Home Care Association. I seem to have a trend today because I had not seen the amendments until I had to actually sign up, since I had to sign up by Friday. So I did see one set of the amendments that address some of our concerns. I appreciate Deputy Secretary Moran's comment about needing to make sure that there were providers at the table. The original bill only had one out of like 13. And if we are going to have a robust program, especially in the Medicare program, the providers need to have a seat at the table. I would argue we probably need to have somewhat of an equal representation. But I look forward to seeing the health department's amendments, and hopefully they address all of our concerns, and if not, I will be voicing that. But we do support the bill with the amendments, and we look forward to continue to work on them.
So, Dana, do you have some additional members in mind that you could share with us?
Yes, I would like to see the composition from the health department's amendments, and then after that, I will be able to give you any additional information.
Okay, we'll be reaching out. Thank you, Dana.
Okay, thank you.
Do I have any other questions for this witness? I don't see any questions. Thank you for your testimony. That ends the hearing on Senate Bill 920. We are now going to have Senator Augustine's here. Senate Bill 790. Senator Augustine, this is your Maryland Department of Health work group to implement early and periodic screening, diagnostics, and treatment requirements.
Yep.
And you have Ann Seacott, Ann Geddes, Antonia Gerard, and Joyce Harrison. All names I can pronounce. Thank you.
Okay. Thank you, Chair Beidel, Vice Chair Hayes, and members of the committee. Senator Malcolm Augustine here, asking for a favorable report with amendment on Senate Bill 790, Maryland Department of Health Work Group to implement early and periodic screening, diagnostic, and treatment requirements. In September of 2024, the Center for Medicare and Medicaid Services issued a state health officer letter outlining best practices for states to improve early and periodic screening, diagnostic, and treatment compliance. One of the primary recommendations was to eliminate the requirement for a formal behavioral health diagnosis before services are provided. Understanding how to apply this guidance is essential to improving Maryland's Medicaid behavioral health system. And colleagues, what this piece of legislation is setting up a work group to study just that. We have been in touch with and working with the department, who would be sort of responsible for this and have come to, we're very close, but what we're working on with them is to use the commission, the Behavioral Health Commission that this body helped to create, and a work group within it that deals with youth to be a place where we'll be able to use that with extended participation of additional stakeholders to complete this study and to do this work in this work group. And so with that, while we're still sort of working out the exact details of that, I will absolutely ask for a favorable report with that amendment and pass it to the panel.
Who would like to go next?
I will.
Okay, thank you.
Hi. I am Dr. Joyce Harrison. I am a infant and preschool psychiatrist. I'm a medical doctor. I have served as a president of the Infant Mental Health Association of Maryland and DC, and I've also been a practicing child psychiatrist at Kennedy Krieger Institute for 25 years now. The bulk of my work currently is working, I am also a trained pediatrician, and so the bulk of my work is working in the pediatric interface between child psychiatry, because that's where our little people live. I lose interest once kids turn around 7 or 8, so I'm very interested in birth to 5 as a very challenging time, psychiatrically, emotionally, developmentally, behaviorally. Kids are very vulnerable, and they're often invisible because they're not in settings where people can know what's going on with them. What I wanted to do today is to really help you all to understand the unique needs of this population in regards to their behavioral health, which, by the way, the AAP sees as health. Behavioral health is health. So these children who present to us, they come to us with behaviors because that's the only way that they can express that there's some distress. But those behaviors can have multiple causes underlying them. And so the process of assessment and diagnosis is even more complicated in this age group. This is what I have focused on my entire career, is actually setting standards, designing standards and establishing curricula nationally and in the state of Maryland to help people working with this age group really understand the complexity of their behavioral health needs. So the process of assessment really is a process, because so often there are developmental conditions that are underlying these behaviors. So they come to us, they're hitting, they're biting, they're aggressive, they're not sleeping. There's a limited range of what they can tell us, but we have to work really hard to get at what is there. So I am running out of time, but I really hope you vote favorably for this work group, because we need it. We need people like me representing our very youngest as well. Sorry.
Go ahead.
Oh, okay. Hi. Thank you, Madam Chair and committee members. My name is Ann Geddes. I'm the Director of Child and Older Adult Policy at Mental Health Association of Maryland, and in that role, I chair the Children's Behavioral Health Coalition. CMS, as was said, recently put out guidance recommending that states should avoid requiring a child to have a specific behavioral health diagnosis in order to receive services, especially children under the age of 5. This is not currently the policy in Maryland. Senate Bill 790 directs the Maryland Department of Health to determine how they will revamp the current policy to align Maryland's practices with CMS guidance. This change is needed for the reasons you heard from Dr. Harrison. I just want to add that it's critical that representatives named in Senate Bill 790 are included in any work group. The commission established by the legislature on behavioral health care treatment and access, their subcommittee, which is entitled Youth Behavioral Health, Individuals with Developmental Disabilities, and Individuals with Complex Behavioral Health Needs, somewhat shockingly, has no members that have a background in children's mental health, much less early childhood behavioral health. In order to produce a good final product, we need knowledgeable and experienced stakeholders participating in this work group. I ask that you include, make sure they're included as they're written in the bill. And I thank you and ask for a favorable report on Senate Bill 790.
Thank you. Who's next?
Good afternoon, Madam Chair, Mr. Vice Chair, and members of the committee. My name is Antonia Gerard, and I'm a clinical psychologist and assistant professor in the Department of Psychiatry at the University of Maryland School of Medicine, Baltimore. and represent the Tagi Madaresi Center for Infant Study there. I've been a psychologist for 10 years and serve as the director of the Psychological Assessment Program and implementation director for Maryland's Healthy Steps programs, an integrated pediatric primary care model embedding early childhood developmental experts in pediatric practices within the University of Maryland and Johns Hopkins medical systems. I'm here today in strong support of Senate Bill 790. Currently, clinicians must render a behavioral health diagnosis to bill for services, forcing them to assign diagnoses prematurely without fully considering the underlying causes of a young child's behavior. I recently assessed a 2-year-old boy referred due to aggressive outbursts and difficulty controlling his behavior. He could have easily been diagnosed with oppositional defiant disorder. However, as I spoke with his mother, I learned his parents recently separated, he had witnessed domestic violence, and his mother was struggling with her own mental health and substance use, as well as financially. His outbursts weren't signs of a mental disorder. They were the reactions of a child struggling with significant instability and stress. This is why we must reconsider the current billing system so that we do not mistake symptoms of hardship for pathology and in turn fail to address the root causes affecting children's well-being. Senate Bill 790's proposed work group should include early childhood mental health experts to address the unique needs of children birth to 5 and explore the benefits of using Z codes to address social determinants of health without prematurely diagnosing young children, as well as consider the DC 0 to 5's diagnostic tool for identifying mental health and developmental disorders in children 5 and under. These steps would support early, accurate identification and treatment. For these reasons, I urge a favorable committee report on Senate Bill 790.
Thank you, and Ann, you're last.
Thank you, Madam Chair. And Mr. Vice Chair, members of the committee, I'm Ann Seacott. I'm wearing 2 hats. Testifying on behalf of the Maryland chapter of the National Council on Alcoholism and Drug Dependence, as well as Inseparable, a national organization advocating for children's mental health. We fully support the bill. As the sponsor acknowledged, and we very much thank him for his support, we are negotiating with the department on the right language to do this so that it does not create a burden on them administratively, but does obviously have significant integration with the work that they're doing. You heard us last year talking about this issue, about no diagnosis for kids. It's now we have this additional best practices document from CMS. We are heading in the right direction. We believe that the department really wants to head in the right direction. We just need to make sure that what's happening, that the things that get implemented are really well informed by the experts in the field, such as you've heard from here, as well as you'll see in the bill, people directly impacted. I mean, it matters that things are very practical. We want to make sure they're correct clinically. We also need to make them practical for when it comes to families seeking help, especially for the very young children. And so we know that this committee and the General Assembly are very interested in children's mental health, especially facing potential cuts to school mental health services. We need to make sure we're doing everything we can at the front end, the upstream end, to try to get ahead of things. So we ask for your support on this.
Thank you. Do I have any questions for this panel? I don't see any questions. Thank you very much for your testimony.
Thank you.
And that ends the bill hearing on Senate Bill 790. And Senator Augustine is still with us. Senate Bill 900, Maryland Behavioral Health Crisis Response System, integration of 988 Suicide and Crisis Lifeline Network. Senator Augustine and Dan Rabbitt.
Yep.
There's Dan. Thank you.
Okay. Thank you, Chair Bidle, Vice Chair Hayes, members of the committee. Senator Malcolm Augustine here presenting Senate Bill 900, Maryland Behavioral Health Crisis Response System, integration of 988 Suicide and Crisis Lifeline Network, and outcome evaluations. So, colleagues, as you well know, we are very supportive of 988 as being our front end for us in the entry point for our for our behavioral health system. And what Senate Bill 900 does is establish a statutory expectation that 988 Suicide and Crisis Lifeline be integrated into Maryland's crisis response system. It really also does incorporate data collection for 988 calls, text chats, and other crisis providers, including the volume, the answer rate, call disposition, things that we know are extremely important. And it also looks at dispatching on mobile crisis teams and response times, and crisis stabilization, center utilization, and discharge outcomes. And it tracks law enforcement involvement and voluntary status of clients, diversion from higher levels of care, including hospitals, and then mandates that data be publicly reported annually and disaggregated by race, gender, age, and zip code to ensure equitable delivery. Similar to the last bill, been working hard with the department, and there was an amendment that was should have been submitted, which would be a sponsor amendment as well, just to sort of get alignment with the department, and that it recommends that we clarify it's Maryland versus the 988 entities, and add that Maryland 988 call, text, chat centers must coordinate with mobile crisis response and stabilization and other immediate services, and refine law enforcement engagement and data elements and the vehicle for consumer experience reporting. Supportive of that to the bill, and so with that amendment, I would ask for a favorable report on Senate Bill 900. Thank you.
Thank you. Dan?
Thanks. Hello, Madam Chair, members of the committee. For the record, my name is Dan Rabbit, Policy Director for Behavioral Health System Baltimore. We're the local behavioral health authority in Baltimore City. We support SB 900 as a straightforward, modest bill to accomplish two goals. One is, we've done a lot of work to invest in 988 and in the crisis response system, but the statutory definition of the crisis response system was drafted before 988 existed. So right now, the way that it's drafted doesn't have any reference to 988, and we want it to accurately reflect how things work today after the 988 system launched. The second goal is to improve outcome reporting. Again, we've done so much to expand and strengthen the system. We would like to have clear, comparable data from jurisdiction to jurisdiction, region to region. We've had really great conversations with the department. They're in alignment with these goals, and we support their amendments. And we think that it will give y'all and the public more transparency to know how we're doing, where we need to improve, where we need to invest. And for those reasons, we ask for a favorable report. I know there's a modest fiscal note, but we think that is a reasonable request. It's half of FTE. To be able to have accurate and transparent data reported every year. And to the extent that there's any other amendments or tweaks or requests from other stakeholders, I haven't seen any, but we're happy to work with them to come to an agreement as well.
Any questions for Senator Augustine or Dan? Seeing no questions, thank you very much. We have two favorable with amendments. Leslie Fry and Tanya Schwartz.
I actually did share some of that.
I saw the email. I haven't seen it official.
Okay.
Thank you.
Yeah. Would you like to go? You can go. For the record, my name is Leslie Fry. I'm here today on behalf of Montgomery County Department of Health and Human Services, and I just quickly want to mention the amendments that are included with our testimony. Montgomery County's crisis response system predates the 988 implementation, and so the first amendment we're requesting is just a slight tweak to the language to reflect that we don't have a single point of entry in our system. It's a coordinated point of entry so that there is no wrong door when people are in crisis and come to the county for assistance, and so that's the first amendment we're requesting, just reflects that. And the second is a change in the due date for the annual reporting. We would like it to begin on December 1, on or before December 1 of 2026. That would give the counties and local jurisdictions enough time to implement the changes under the bill before having to report the requirements under the bill. So just those two small changes, and otherwise we're in full support of Senate Bill 900. Thank you.
Good afternoon, Madam Chair and committee members. My name is Tanya Schwartz, and I serve as the Director of Urgent and Acute Care at the Maryland Department of Health Behavioral Health Administration. The Maryland Department of Health thanks the committee for the opportunity to provide support with amendments for SB 900. This bill aligns with the department's efforts to build a continuum of behavioral health crisis services across the state. We want to ensure that all Marylanders have someone to call, someone to respond to them in that moment, and a safe place to go to stabilize and get connected to ongoing support. As Senator Augustine noted, the department is proposing one addition to the bill and several changes to the original statute to enhance 988 services and reflect current and planned data collection efforts. The department proposes adding that Maryland 988 centers must directly dispatch or provide warm handoffs to mobile crisis response and stabilization services and other immediate services as needed. And this is a critical element of 988 for approximately 4% of people who contact 988 and need immediate in-person support. With respect to the data, the department has been sharing 988 data monthly and working with jurisdictions and providers to improve crisis system data collection. Beginning in state fiscal year 2026, this enhanced data collection will capture the elements outlined in the bill. The department proposes refining the statutory data collection provisions, as Senator Augustine noted, related to law enforcement engagement and voluntary status and diversion from higher levels of care, including hospitals, to more accurately and adequately capture the data the department is able to collect. Additionally, we propose clarifying the vehicle for consumer experience reporting to be completed at the local level. Thank you for the opportunity to provide support for this bill. We look forward to working with you, jurisdictions, providers, to really ensure that behavioral health crisis services are available when and where Marylanders need them most. Thank you.
Thank you. Do I have any questions for this panel? Seeing none, that ends the hearing on Senate Bill 900. We are going to move back up the list to Senator Lamb, who's back with us now. Senate Bill 741. Forensic mental health treatment, and it's joint with JPR, so Senator James will be joining us shortly from JPR. Senator Lamb, you have Courtney Bergen, Sanjeev Berghese, and Teresa Costley's virtual, but she's part of your panel, so we'll bring her in.
Great, thank you. And thank you to, I'm not sure if Senator Augustine's still here for the flexibility. I know there's a big hearing coming up after this one, so appreciate being able to get this one back in. Good afternoon, members of the committee. Chair Beidel, I'm here to be able to introduce and testify on Senate Bill 976. For the record, Clarence Lamb, Senator District 12.
I think it's Senate. Are we right? I thought that's Senate Bill 741.
Oh, 741, sorry.
Thank you. Thought it was
right. I got my numbers crossed. I'm sure there's a bill in dyslexia somewhere here. But I'm confident, like myself and all members of this committee have heard many complaints and lawsuits about the delay in moving individuals from mental health conditions from our local jails to psychiatric hospitals. But what's really crystallized for me the need for the General Assembly to look at this issue more closely was that I have a constituent who has been held in pretrial for nearly a year, at the Howard County Detention Center. And at the end of this week, she will officially have been there waiting 80 days for psychiatric beds, something that the Maryland Department of Health is required by law, that we passed into law, a requirement that they provide those types of beds in 10 days. Another incident that I felt showed the immediate need for action was the story of Richard Hall, a resident of Prince George's County who died in a detention center while waiting for a psychiatric bed. How those that are designated incompetent to stand trial are supposed to work is that if there's a concern about a defendant's competency, the judge must have a hearing, which may include an evaluation by the Maryland Department of Health. If the judge finds that the defendant is incompetent to stand trial, then the judge can release the defendant for outpatient treatment or order them to a hospital. If the defendant is ordered to the hospital, the department has 10 days to place them. That's current law. As far as I can tell, this ideal process essentially is never met. This requirement for 10 days of placement is never met. Defendants with mental health conditions are stuck in jails for months waiting for mental health care. My constituent waited 8 months for a competency hearing and is almost 3 months in just waiting for a bed. These are illegal delays because they're not meeting our statutory requirement that are not only leading to defendants with mental health conditions to further decompensate while in jail, but also putting our local detention centers in a position to provide mental health care to extremely sick Marylanders for which the jails are not fully equipped to care for. This bill does three things as we try to move the needle on this issue. First, the bill creates a work group that will create a worksheet for judges to use for data collection when they're deciding on a competency case. This will help us better understand what is going into making competency decisions, which currently is kind of a big black box in a way, and really depends on where your case goes or is occurring. The work group was also tasked with reviewing the data about each competency case and providing recommendations on things like needed bed capacity and what funding the state would need to address these requirements. Second, the bill requires that the Maryland Healthcare Commission approve a certificate of need when a hospital wants to close 5 or more psychiatric beds. That currently opening new beds requires a certificate of need, which many of us are familiar with and this committee has dealt with before. But closing beds or a hospital does not require any recognition of a certificate of need or similar designation. This creates a situation where it's easier for the state to lose or eliminate psychiatric beds than it is for them to bring beds online. The Maryland Healthcare Commission sent me an amendment to better align with the language of how their process actually works when it comes to certificate of need, and it will still retain a requirement for the commission to oversee and approve the closing of psychiatric beds. Lastly, the bill creates a fund to hold fines that the Maryland Department of Health is court ordered to pay because you may have seen in media reports that because these individuals are being held at hospitals longer than the 10 days, that the department is being held in contempt, the secretary is being held in contempt, and some of the judges have started ordering fines on the department as a result of this. This designates those fines that the department is ordered to pay to be used to place defendants in beds. As noted in the fiscal note, the department is annually fined about $1.5 million. It is not totally clear where these funds are currently designated or going to, but the fiscal note suggests that it's going to the judiciary. By creating this fund, we'll be able to use these resources that are already being court ordered to be paid to actually help address the real issue underlying the concerns. I've received requests from the department and advocates to open up the use of this fund slightly, which I've included as amendments to be able to do. For example, the department highlighted that the big issue with opening new beds is oftentimes a lack of staff, and that it may make more sense to clarify that the funds can be used to also support additional staff. Certainly open to more feedback on what money this could be used for, or what direction or resources these funds could be used for to actually try to help address the issue. Finally, the department has unfortunately given this bill a large fiscal note. In my opinion, we've kind of seen this from the department oftentimes. It claims that it is duplicative of other work that's being done. This claim that work is already being done by the Commission on Behavioral Health Treatment and Access. This is a 40-person commission, I think familiar to this body. It has a very large charge and mission that doesn't explicitly include addressing this issue that we're seeing here. We have countless Marylanders who are currently stuck in our jails without treatment, and the department is being fined over $1 million a year because we're not able to meet the statutory requirement of placing them in beds as needed within the 10-day requirement. This issue needs more targeted focus, in my opinion, and should not simply be added to a very large list of charges that the Commission on Behavioral Health Care Treatment and Access already has. I don't think, and I disagree with the fiscal note here, I don't think that the department will need over $100,000 in staff for this work group, but I have reached out to other stakeholders to see if they can help pay for staffing for the work group. The department also mentions that the certificate of need requirement would result in them needing certificates of need when they have to temporarily close a bed for maintenance. The Maryland Healthcare Commission that handles certificates of need reports that this is correct and that this language would only apply this is incorrect, rather, and this language would only apply to the complete closing of a bed. With that, that is the bill. I'm happy to hand it over to other members of the panel and take any questions at the end.
Thank you, Senator. Mr.
Varghese, thank you. Good afternoon, Chair, Vice Chair, members of the committee. I'm Sanjeev Varghese with the Public Defender's Office. I'm in the mental health division there. And let me preface by saying that OPD cannot offer advice or recommendations regarding how the money is going to be allocated or spent. But we are willing to take on the burden of staffing the work group with partnerships with the other stakeholders in it. The work group, from my understanding, would be the only work group that has the judiciary and the department both on it. The work group would act almost as a risk management tool that you see in hospital settings to do a root cause analysis to understand what's happening in the system when you have these adverse outcomes to prevent them from happening again. The lack of beds and the capacity at the Department of Health is an ongoing problem that's been present for more than a decade. This problem has persisted with contempt orders being held against previous secretaries as well as previous other department personnel. It's not just new to this administration alone. The issue of having the beds being held for those individuals who are incompetent to stand trial and not getting the treatment they need can be modified by having a second bail hearing, which is one of the amendments I believe Senator Lamb has proposed, where if they're in the hospital, they have a second bail hearing before they are sent back to the jails. Maybe at that second bail hearing, they can find services in the community for outpatient treatment. One of the issues is that when they're sent back to the jail, the formularies that they're receiving at the jail for those same psychotropic medications are different. Those psychotropic medications are not then the same. They may be used for antipsychotic purposes, but they're going to have a different effect on different individuals. They go back to the jail, they decompensate, and they're sent back to the hospital. It's a revolving door at times that prevents access to care and treatment. As for the certificate of need, it shouldn't be easy to just close down a hospital setting and beds. The certificate of need for the state hospitals is currently not being fully utilized. If I may just briefly, thank you. There are units at the state hospitals that are not staffed, they're not even open. They are sitting vacant because they don't have those staffing levels. The work group would also help to address where are the limitations and what is preventing the department from actually fully staffing and providing care congruent with the certificate of need that was allocated for those psychiatric beds. We urge a favorable recommendation with the sponsors' amendments.
Thank you very much. Courtney, thank you.
Hi, my name is Courtney Bergen. I'm an Equal Justice Works Fellow at Disability Rights Maryland, and I'm here in support of Senate Bill 741 because the forensic mental health system in Maryland is really in crisis, and we believe this bill takes critical steps to address this crisis. And two of the things we really want to focus on is when the fund that's being created for treatment, we believe that the contempt fines that are being levied against the state really need to be directed towards solving the problem in order to compel compliance with the 10-day timeline that you all have set forth for transferring individuals to state facilities. Currently, these individuals, as Senator Lamb pointed out, they're spending months in jail. I think the current time frame is estimated to be around 50-something days, but I've personally not seen somebody in jail less than 3 months. So we really believe those fines need to be directed towards treatment. And we also just want to suggest that they not, as Senator Lamb mentioned, that they've used more broadly than expanding hospital beds. We personally do not believe that hospital beds is even the root cause of the problem, but rather there's a kind of a bottleneck that's being created because there's not enough specific outpatient placements to discharge people promptly. So I think last count I saw was 130 or something people were ready for discharge, but couldn't find placements. We believe directing to community placements is really important, and then community-based competency restoration so that many people never even have to go to a hospital. That's a good majority of the people. And then we also really want to support the work group. A similar work group existed in 2016, made some really critical recommendations, and DRM would be happy to participate in a work group like that so we can be part of the solution. So with that, we ask you for your support. Thank you.
Thank you, Courtney. We're going to hear from one witness virtually and then have questions. So Teresa Costley. Is Teresa on? She's there. Okay, let's give her a minute. There we go. Hi, Teresa. Unmute and give us your testimony. You need to unmute, Teresa.
Hello, can you hear me?
Now we can, thank you.
Okay. Yes, my name's Teresa Costley, and I'm very happy to be here to testify today. My daughter Tammy was admitted to Howard County General on an emergency petition on April 1st of 2024. She was diagnosed paranoid, schizophrenic, bipolar with suicidal tendencies. She was then discharged on April the 7th to the detention center. On December 17th, she was found incompetent and the judge ordered her to be sent to a hospital within 10 days. Today is March the 4th, and she is still at the detention center. When she asked about this to the staff at the detention center, she is told that she goes on the bottom of the list because she takes her medication. It is not the proper medication she should be on. However, it does help her. Now, she feels as though should she stop taking her medication so she can be sent to a hospital quicker. And I encourage her not to do that because I'm afraid that if she were to do that, she would start to hear voices again and could possibly become suicidal again. It's a shame that these people are warehoused in the jails. There should be enough beds available for them in the hospital. You know, I want my daughter to get the help she needs, and she knows she needs this help. So if you guys could please help them, help her, help the other patients that are in there, I would so much appreciate it. And I really appreciate Clarence for even bringing this up. He's done a great job. And
Thank you, Ms. Costley. Thank you, Ms. Costley. Now, do I have any questions for the senator, this panel, or Ms. Costley? Any questions? Our visitor from JPR, sure.
Thank you, and thank you, Senator Lamb, for bringing this bill. In our committee, the JPR committee, we are also struggling with this issue because we obviously hear from corrections, and even my own local sheriff says, I feel like I'm running an incompetent mental health and drug rehabilitation center, and that is neither of the things are what I should be engaged in. So you're bringing up that issue, but I did just have a couple of quick questions. The law in the fiscal note says the court may order individual defendants to these facilities. So I'm trying to figure out whether the problem is that the courts are doing this and there's no capacity, or are they not making these referrals, this may transfer to a facility. It's on, I'm sorry, they don't number these pages, but it's under current law about 4 lines down. The court may order the defendant committed to a facility designated by, the Department of Health.
Yeah, so, and I think the other panelists can also add to this, that is up to the judge to make that decision based on kind of the totality of the picture of that patient, whether they should go to a facility or not. The concern here is that there simply aren't enough facilities or beds for them to be able to go to.
I was trying to figure out, terrible question. I was trying to figure out whether the heart of the issue, because it's not a mandatory, I was surprised it's not mandatory, but is it that the judges are not availing themselves of this opportunity and therefore these individuals are staying in jails, or is the problem they are making these recommendations but there's no capacity, or is it both?
I think it's more the latter, that they are making these referrals, that there are people that appropriately should be in some of these beds, and there simply isn't the capacity of the beds or other resources like staffing to be able to staff these beds.
The other question I had is somebody mentioned, I think it's the person on Zoom, that it's not, I think everybody agrees it's not so much a bed issue, but maybe staffing, at least I heard that. But someone else said, look, the other problem is there's not enough capacity in the community. But my question was just so I can understand the bill and the situation. A lot of times these individuals are determined to be a danger to themselves or to others. So even with that, is the testimony that they can be, taken to a community setting that would not be perhaps as secure as certain hospitals and, prisons?
So I think others in the panel can speak to this, but I think it's to the level that's appropriate for that patient, right? And so if that's a safe environment for the patient, then that could be the designated location. Obviously, it's not appropriate for everyone. So, I think that's where there's a judgment that takes place, taking into account kind of the clinical picture of that individual as well as, what's the most appropriate in terms of safety and such. But.
And here's my last question. Since this has been going on forever, and I was started down here in '98, and we've had all these continuous contempt, and you're absolutely right, it predates Governor Moore's administration. It's a systemic problem. How do you envision this bill making progress in the sense that you're in court with a contempt proceeding, you're being fined, and yet still we're not addressing the problem? What do you think is key to this bill, the language or any way you approached it that will force this to be resolved in a better fashion when contempt proceedings and fines over years and perhaps decades has not produced the results we need?
So I think this is one way to be able to try to address the problem that we're seeing, right? That there simply aren't enough beds. The department and the secretary is being held in contempt. The judges are using every tool that they have to try to get these individuals, these patients who need this care, into the appropriate beds. And the only tool that they have left remaining that we've equipped them with is finding the department and finding the secretary. Finding the department, basically. Where there's a disconnect here, and what this bill tries to connect back together, is that the fines from that are actually going back to the general fund. And what this bill intends to do is say that those fines that are being levied against the Department of Health should go back towards making sure that we can have more beds. Whether that's, staffing, for example, whether that's resources that are needed to open up beds, whether it's community support, resources for people that can be appropriately designated to those kinds of locations. It just says that the funding that the department is being fined at should actually go back to trying to solve the problem.
Well, I definitely think that is a very clever approach for the money. I think I share everybody's frustration that so many things have not worked. And as a lawyer, I look at contempt proceedings and fines as the ultimate, and it should bring about a result. And I was, I hope this approach works. Thank you, Madam Chair.
Thank you for your question, Senator. Okay, I don't see any other questions for this panel. We have.
If I may address further the question. So my apologies. I think one of the issues is that second bail hearing would allow people who are IST in the hospital not to be sent back to the jail. That would provide, because if they're at the hospital with MDH, their insurance and their services, the medication that they get are going to be different than what they're getting in the jail. So if they go to the jail, they could decompensate and go back to the hospital again, thereby taking up a bed. If they have that second bail hearing, they could go to like a residential rehabilitation program or other services in the community to prevent them from actually needing inpatient treatment.
Thank you. Thank you for your offer to staff the work group, too. We appreciate that. Thank you. We have Paul Ellington as a favorable and Dan Rabbit as a favorable with amendment.
Hi, my name's Paul Ellington. I'm here with For All Seasons, behavioral health services provider, but we also provide services to the jails, many jails on the Eastern Shore. And I think the senator, as did Senator James, touch on the red tape problem that we have. And nobody wants to go after the certificate of need. That's for another argument. But what we're trying to do is support, what the senator's trying to do is to close the gaps, get the mental health care, because we believe it's holistic, that a lot of the times the people that are in the criminal justice system, maybe they don't need to be there. Maybe they need to be somewhere else, but we're hamstringing the process. And so we see the benefits of this bill by taking the fines and directing them to mental health and not just the judiciary's general fund. So I will close by just simply saying that this is a problem that we all face, and it's a problem that nobody really wants to talk about. They think out of sight, out of mind, but we deal with these people every day. They're good people that are in need of help, and if this bill can help direct the funds where they're most needed, not only to the patients, but to adequate staff, then by all means, we ask for a favorable support of this bill, a favorable report on this bill. Thank you.
Good afternoon, Chair Beidel, members of the committee. Again, my name is Dan Rabbit, Policy Director for Behavioral Health System of Baltimore. We're the local behavioral health authority for Baltimore City, and we're deeply concerned about this issue. Locally, we're working with our jail and with the courts every day to try to address this problem. So we're favorable with amendment for SB 741. Our amendments, we think, are friendly. We would like a member of the Maryland Association for Behavioral Health Authorities to be a part of the work group as the local community mental health overseer of all the counties. And we would like the fund that's created in the bill to be able to go towards not just psychiatric inpatient beds, but also towards outpatient community resources. The solution we try to use locally is to try to see who is not violent, who is not dangerous, whose competency could conceivably be restored in the community. So not everyone has to go to the hospital, but also, like, in order to get people out of the hospital, you need community resources. So we think that's just a really critical part, and we don't want the scale of the attention to go too much towards inpatient. We want all the issues to be considered. And so one last thing I'll say is that the Commission on Behavioral Health Access and Treatment is not the right place for this. Like, we need a deep dive that looks at things case by case. It's so complicated. And that commission just has so many charges and so many people on it. I don't know that there's anybody from the courts. They don't look at the level of detail that's in here. So we think that a separate targeted approach is really needed because it's that big of a problem.
Dan, in Anne Arundel County, we now have a mental health court, which started just a few months ago. I was at the opening. Do most counties have that?
I believe so. I know Baltimore has had one for a number of years. We have a drug court as well, homeless court, like problem-solving courts, and they're helpful. But I think, and this isn't my area of expertise, but that's where I think people who may be found guilty of issues rather than incompetent to stand trial
not just
are diverted. But it's certainly a part of the solution, and that's why we want to look comprehensively.
Thank you for that. Senator Mounts has a question.
Thank you, Madam Chair. And Paul, so did you say For All Seasons has an amendment? They were just in support?
We're in support of the bill with his amendment.
Gotcha. Thank you.
Thank you, Senator, for clarifying that. Okay, I don't see any other questions. Thank you, gentlemen. That ends the hearing on Senate Bill 741. And our last bill of the day, and thank you, Senator James, for joining us. Our last bill of the day is Senate Bill 720. Lots of testimony, but we're going to bring up Senator Augustine. And your panel is Anna Palmisano, Andre Johnson, Bridge Dumais, Lorraine Ericott, and then virtually we'll have Danita Tolson before we go for questions. Thank you.
Thank you, Chair Beidel, Vice Chair Hayes, members of the committee. Senator Malcolm Augustine here asking for a favorable report on Senate Bill 720, Clinical Staffing Committees and Plans Establishment at Hospitals, Safe Staffing Act of 2025. Colleagues, 1 in every 4 hospital nursing positions in our state are vacant, and 62% of nurses say they are considering leaving the profession. They are facing unsafe staffing levels, lead to medical errors, high mortality rates, healthcare worker injuries, and burnout, quite honestly. It's simply not a sustainable situation that we have right now. And of course, we know it's been contributing as well to a lot of our issues and concerns in our ERs and what those ER wait times that we have. So what this bill does is this bill will ensure that every hospital in Maryland creates a staffing committee in which half are direct care workers representing the entire care team, which means nurses, physicians, technicians, support staff, environmental service workers, and dietary aides. And a patient advocate will also have the opportunity to join each committee. Hospitals also have flexibility to amend staffing plans as needed, especially if they see they are unable to meet recommendations. And they encourage staffing committees to problem solve until a feasible solution is found. Now, what we know is that safe staffing committees improve quality of patient care and working conditions for the care team and reduce those ER wait times. It also fosters collaboration between the care workers, management, and patients. And those guidelines are formed from the committees will be flexible to allow each hospital to create and adjust the staffing guidelines based on their unique needs. A diverse care team will encourage that problem solving. We'll also, with this bill, collect and share data on worker retention challenges and outcomes of staffing strategies with the Maryland Department of Health and the Maryland Emergency Department Wait Time Reduction Commission, with the end goal of enhancing recruitment and retention of healthcare workers. Quality care begins with patient worker-driven flexible staffing plans. This is not unique to what we are doing here. What we're proposing to do is not unique in this country. I mean, 9 other states have passed legislation to create clinical staffing committees in hospitals, and the research has shown that it improves the worker engagement, workplace conditions in very, very meaningful ways. And so this is significantly why we are in support of this bill. We also had a recent report from our commission to study healthcare workforce crisis in Maryland that made clear we need more data about our healthcare workforce. And Chair Bidel was a champion of that commission, and just really grateful for that and for the data that has been collected on staffing conditions. And we want to make sure that we have that valuable to create this data-centered policy decisions to improve job and care quality. The bill has been discussed, and we've met with the Department of Health and also with the Maryland Hospital Association, and it has broad support, which you surely will be able to see and you will hear from. There are a couple things that I definitely would want to share, because you'll hear opposition that will talk about whether or not this bill mandates staffing ratios and will it negatively impact hospital budgets. And the bill just doesn't do that. It does not have the impact on the hospital budget or lead to bed closures, because hospital management has the opportunity to amend staffing plans based on feasibility. They're still in control. This bill is flexible. The guidelines, they're not mandating ratios or anything like that. Some of the hospitals also have shared with us in the meetings that we had that they already have shared governance models, which we think is great. I think that's great. I was very pleased. I was a little disappointed when I asked for some of the for them to share some of that information with me, and they didn't do that. But I mean, hopefully at some point we'll get more collaboration with the folks who are there and are part of that. Because those shared governance models make sense. I mean, that's what this is. That's what we're talking about. And this is meant to be additive to that. When they talk about them at the unit level, this is to be additive to that process, not to take away from it. So those separate staffing committees for the hospitals that are at the unit level, this is not replicating that. This is an effective process for at this higher level that we know will really benefit the hospitals and the overall ecosystem of that hospital. And there have already been instances where this work has happened together with the stakeholders, including Maryland Hospital Association. They've done that with 2 labor and management committees on safe lifting and joint workplace violence. And those things have been successful. So, we can make these kinds of things work. We really can. We also might hear that the state's already working on addressing the healthcare staffing crisis, and we're already kind of there. We know that's not the case. I mean, we know we're struggling, right? We got to do better with our healthcare workforce, and this is a proven method that can really help to address this matter. You also might hear that you may be asked questions like, well, why aren't state hospitals included in this? And we just heard from that last bill, part of the complications and the reasons why our state hospitals and our care of those who are in the care of the states is very, very different than other than the general hospital systems. They really are different, and they have really very, very different requirements, and it's a reason why they're not a part of this bill. And so I just want to really say, like, for me, what this really is about is that the hospitals get the benefit of the expertise and the experience of their absolutely greatest asset, which is their employees. That's what this is about. It's just making sure that we're able to do that. And with that, I'm going to ask for a favorable report on Senate Bill 720. Thank you.
Thank you, Senator. Lorraine, you want to go next?
Good afternoon. My name is Lorraine Arikat. Today I'm speaking on behalf of the Patient Worker Collaborative, a new coalition of patients and their families, healthcare workers, and community partners in favor of SB 720. Our coalition represents over 1.2 million Marylanders affected by the hospital short-staffing crisis. This bill has support from patients, physicians of MedChi, emergency responders of the Black Chief Officers Committee, the Alzheimer's Association, and many more. Maryland has the worst ER wait times in the country for the past 9 years. It is 46th in staffed beds, and it has 1 to 4 nursing positions that are vacant. Studies have shown that short staffing correlates with increased patient deaths. For example, it takes 2 workers to properly do wound care. When they are short, workers are either forced to provide care alone, which can hurt the patient or injure the worker, or delay care while they wait for help, potentially leading to infection or sepsis, which can be life-threatening. These are impossible choices for workers and lose-lose scenarios for patients. The current approach to addressing the workforce crisis is not effective. Workers describe hospital staffing as a revolving door. Hospitals offer sign-on bonuses and try to bolster education pipelines, and they are still understaffed. Recruitment is valuable, but it is not alone enough to retain workers when their ideas never make it further than a suggestion box. The best way to bolster a new generation of workers is to give them a seat at the table where they get to be part of real solutions, and that is what the Safe Staffing Act will do. This bill offers a unique opportunity to track how staffing conditions impact hospital expenditure and quality of care. Staffing committees allow each hospital to tailor staffing plans to its most pressing needs. This bill passed the House last year, and we expect it to pass again this year. Senators, we call on you to vote yes on the Safe Staffing Act.
Thank you, Lorraine. Anna, you want to go next? Want Bridge to go next? Yeah. Okay.
Good afternoon, Madam Chair, members of the committee. My name is Bridge Dumais with 1199 SEIU, the largest healthcare workers union in the nation. Over 5,000 of our members work in dangerously understaffed hospitals across the state. Their experiences prove that short staffing is pervasive and can have serious consequences on both quality of care and workplace safety. When I ask workers to describe the impacts of short staffing, the common themes are delayed patient care, burnout, and that workers are not listened to when they raise alarms about this crisis. 1199 urges a favorable report on SB 720 to enable worker-driven solutions for safe staffing. At a hospital where 1199 has members recently, there were not enough workers in the behavioral health unit to do patient wellness checks every 15 minutes, as is best practice. Tragically, a patient committed suicide in that hospital. At Capital Region Hospital, a member of 1199 was brutally beaten by a patient. She was the only worker on the floor. No one was there to intervene or de-escalate. Our member was so injured and bloodied that she couldn't get herself up, so another patient had to go to a different floor to get help. Short staffing is traumatic for both workers and patients. When workers' ideas are not incorporated into staffing plans, as is current practice without SB 720, management often comes up with solutions that are unsuccessful because they are just looking at metrics and they don't think about the workers as human beings. One hospital's attempted solution was to change workers' shifts so that there would be staggering times for clocking in and out and to require workers to start coming in every other weekend. That plan backfired. Workers struggled with childcare and transportation due to schedule changes. Ultimately, more workers called out or just quit because of the increased burden on their lives. The Safe Staffing Act not only gives workers a voice, it gives hospitals the benefit of implementing staffing plans that will actually work. Please vote yes on this bill. Thank you.
Thank you, Bridge. Anna, now.
Madam Chair, Vice Chair, and committee members, I'm Dr. Anna Palmisano, the Director of Marylanders for Patient Rights, the largest patient advocacy coalition in the state with a collective membership of over 1 million Marylanders. We have joined healthcare workers in a patient worker collaborative to support the Safe Staffing Act of 2025. I'd like to talk about the consequences of failing to provide safe staffing. A young friend went into labor in a high-risk pregnancy with twins, so she went to her local ER. After waiting in extreme pain for 8 hours, worrying about her survival and that of her 2 babies, in desperation, she called her Maryland state legislator, who then called the hospital CEO, who then called the ER lead, who then ordered an emergency cesarean section. Now, all lives were saved despite this egregious violation by the hospital of the federal EMTALA law, but will this become the new triage process? I spoke to the president of the Maryland Continuing Care Residents Association. At his retirement community, residents are so concerned about Maryland's long ER wait times that they have lined up some of the other seniors in the community, those that still drive, to take them across the American Legion Bridge to Virginia for care. Why? Well, they're afraid of the long wait times at their local hospitals, and Northern Virginia hospitals have much shorter wait times and 30% more staffing. Without a safe level of staffing the ER, Maryland patients will continue to suffer long and potentially life-threatening waits for emergency care. The Safe Staffing Act will bring the knowledge and experience of direct care workers to bear on reducing ER wait time and improving overall quality of care. I ask for a favorable report on SB 720. Thank you.
Thank you. And Andre Johnson?
Good afternoon. My name is Andre Johnson. I've worked at the hospital for 26 plus years in the environmental service department. Every department from EVS to nurses, general staffing, transport, nutrition workers are dangerously short-staffed. Patient care is the #1 goal of every hospital, but short staffing is hurting the quality of care. That's why I support the Safe Staffing Act. The whole care team contributes to the wellness of the patient. My department keeps the hospital clean, which is important in reducing the spread of infection. Years ago, before the pandemic, my department had over 700 workers. As of last year, 400, and today, even shorter. Around 5 people call out every day. Workers do our best, but one person can only do so much. Hospitals are meant to function as a team setting, and we can't work as a team when we are so understaffed. Short staffing puts so much pressure on the workers, we put our own health at risk, and stress kills. Workers still have to feed our families, and that fact is used to manipulate us into working in unsafe conditions. We do multiple jobs all at once because we don't have the luxury of quitting and starting something new. Our vacation requests are frequently denied, and when we ask why, we are told that it's because of short staffing. We work hard to earn our paid time off. It is the responsibility of management to staff the workplace appropriately so that we have the benefit that is owed to us. How can we maintain a high work value and performance when we can't even take a break and are burnt out from being overworked? It's like a tire stuck in the mud spinning its wheels. but not going anywhere. I was raised to stick up for people who need help, and I raised my children and grandchildren with this value as well. My coworkers and I are being ignored by hospital management. We need the Safe Staffing Act, and I will gladly be a volunteer on this committee when this bill is passed. Please vote yes, and thank you.
Thank you, Andre. Now we have one witness virtually, Danita Tolson. Danita, you want to unmute and give us your testimony?
Thank you. Greetings. I'm in favor of Senate Bill 720, Safe Staffing Act. I'm a registered nurse and the Maryland State Conference NAACP health chairperson. I have worked with patients and students to try to get patients in and out of hospitals in a timely fashion. Who determines the waiting time for patients? Triaging patients, then sending them back in the waiting room is not cutting down on the patient's waiting time because the patients are still waiting. What is a safe nurse-to-patient ratio? Doing vitals is not cutting down on the waiting. It's just a cushion to hush the patients until they are seen by the doctors because they are put back in the waiting room. The patients are being charged by the hospitals from the time of triage while they are waiting. We don't have enough nurses and staff to take care of patients or cut down on the waiting times. Nurses and staff who are overworked and understaffed may cause medication errors and may cause unsafe patient practices that lead to nurse or staff burnout. The goal is to decrease medical errors by improving safe staffing. More people die from medical errors than motor vehicle accidents, breast cancer, and AIDS. There are more than 1 million people injured in the hospitals because of errors, and most are preventable. Sometimes patients are in the hallways waiting on stretchers. Increased wait times in the hospital increases the risk for spread of infections from other patients. The fact is, hospitals are starting the waiting times all over when the patients go back in the waiting area. Are we truly at the number of patients, looking at the number of patients who leave the hospitals because of the long waiting times, because of poor staffing, and how we can be more efficient? We need to track the patients leaving compared to the waiting times. I ask that you are in favor of Senate Bill 720. Thank you.
Thank you, Danita. Now, do I have any questions for this panel? I do. Senator Gall?
Thank you, Madam Chair, and thank you, Senator, for this bill. I think this is a question for the bill sponsor. Senator, I was looking at the bill, and I'm trying to understand, I don't know if it's different from last year but the bill, you had said that the bill doesn't mandate ratios because hospitals retain the flexibility to amend or alter the required clinical staffing plan based on feasibility.
Yep.
Could you tell me, is it in the bill specifically where hospitals have the flexibility to alter or develop the required clinical staffing plan based on feasibility?
Go ahead.
Or maybe somebody else can respond too. It doesn't have to be, whoever else can help me understand that.
Yes, it's directly in the bill, probably the third or fourth page where it says hospitals are able to amend staffing plans. And that's really the purpose of the staffing committees is they recommend based on worker experiences and voices on what needs to happen on floors and units. And if something's not feasible, they bring that back to the staffing committee and they problem solve, right? They're able to come back and say, this didn't work, what can work next time around? And so they can amend the staffing plan as needed. And that doesn't stop them from making that change on the day of or whichever day that needs to be changed. They just come back to the staffing committee at the next monthly meeting and mention that to the committee that it had to be changed.
Okay, so they can do it on the spot and then report it back, I guess? Is that how it would work?
Yeah, just to make sure that that data is recorded and that the staffing committee has a chance to figure out how do we solve this patient issue or this staffing issue that's reoccurring.
Okay, thank you. Thank you, Madam Chair.
Thank you. I do have a question. I apologize for the late attendance, but everybody's in other hearings. But they can come back and watch this, as you know, virtually. But Senator, tell me again why it doesn't apply to the staff, to the state. If the state is so critically understaffed and yet we're going to exclude the state from this bill?
Because the requirements of the state are very different, obviously, than our hospitals that are for those who are not specifically in the care of the state. I mean, the requirements are different. We have different requirements that we're not meeting them as a state, but that's because of the state's investment or lack thereof in them. But the requirements are just so very, very different because of the inclusion of like the judiciary, for example, with folks who have been they have, if there's been like an emergency petition, these folks they have the requirements for the hospitals themselves, and what they do is just very, very different than would be the case for the other hospitals.
Thank you for that response. I don't see any other questions. Thank you to this panel. All right, now we have, let's see, I have 7 more favorables. I have 6 seats, so maybe somebody's not here and I can do this balance. Tammy Bresnahan, Antonia Brooks, Roxanne King, Christopher Cano, Erica Puntes. All right. I think I'm going to wait so that somebody doesn't have to come up all by themselves. So, okay, Tammy, would you like to start? Sure.
Good afternoon, Madam Chair and members of the Senate Finance Committee. My name is Tammy Bresnahan. I'm the Senior Director of Advocacy for AARP Maryland. You have my written testimony. I don't think the other panel went into all the specifics. We've been here for years talking about emergency rooms and hospital wait time. I just want to tell you, I think it can be done. And because on February the 16th, I slept in a restaurant in Pocomoke City, Maryland, and I hit the wall and put a gash in my head and landed on my thigh, and I was rushed to Tidal Health in Salisbury. And from the time that I got there, 25 minutes from Pocomoke City to Salisbury, I was in there at 9:40. And by 11:40, I had 4 staples in my head. I had had a series of x-rays, and I was released from the hospital. 9 people administered my care there. I never saw the doctor. I know there was a doctor on staff, but the physician's assistant was the one who ended up putting the staples in my head. So I know it can be done. I know that people aren't going to be stacked up in the hallway. I thought I was going to be stacked up in a hallway based on my previous experience with my husband at Luminous Health, who was there, rushed to the hospital, and was there for about 8 hours. So I know that staffing has been critical for the hospitals. We know it can be done. They're doing it in some other places. And so we'd like to get a favorable report on Senate Bill 720. Thank you.
Good evening. My name is Antonia Brooks. I'm Physical Medicine and Rehabilitation Tech 2 in Intensive Care Unit, a member of 1199 SEIU. I am a healthcare worker because I care about people. I believe healthcare is a human right. Short staffing delays the right. I urge a favorable report on SB 720, the Safe Staffing Act. At my hospital, there are long emergency department waiting times, delayed inpatient care, and patients are being treated in hallways. I work short staff at least twice a week. I treat 24 patients a day, helping them walk and sit up, provide respiratory assistance. On days we are short, I assist in other areas as well. So I spend much of my time with patients on those days. Treatments that patients supposed to receive daily often get postponed. We are short-staffed because healthcare workers are underpaid, overworked, high patient volume, running from building to building is exhausting. New workers quit soon after being hired when they are asked to take over work outside of the job description. Some call the hiring process false advertising. When workers bring in our concerns about safety, staffing to management, they act like they are not listening, but they don't use or suggest suggestions, so the problem isn't getting solved. The Safe Staff Acting will change that by giving workers like me a really opportunity to bring solutions to the table. I'm excited to volunteer for service on a Safe Staffing Committee. When this bill is passed, please vote yes on SB 72. Thank you.
Thank you. Who's next?
Greetings, Senator Bidle, and also members of the committee. I'm Roxanne King, and I'm co-vice president for public policy for American Association of University Women of Maryland. And a lot of us have a lot of gray hair, and we're concerned about staffing in the hospitals, but especially concerned about emergency room staffing. I'm just going to relate a story, but we believe that that this bill can have an influence on it, and we also believe that Maryland can do a lot better than last place in an emergency room wait time. One of our members, Susan Crawford, related that in October 2023, her husband Jay nearly cut off a finger using a table saw. They arrived at University of Maryland Baltimore Washington Medical Center around 3 on a Saturday. Around 5, they asked if someone would look at his finger because it was bleeding a lot and they didn't want to lose it. They were offered more paper towels, taken to a room, and sat for another hour when someone came in, looked at the hand, and took pictures. Around 8:30, the night doctor came in and offered to cut the finger off several times. No orthopedics doctor was available, and no ambulance was available for transfer to MedStar in Baltimore. At 9:30, ambulance transfer was still not available, and they were not allowed to go to MedStar unless by ambulance. Shortly after deciding he would have to spend the night, at 10:30, the staff agreed that the couple could drive themselves to MedStar. Paperwork was sent, and by 11:30, an orthopedics hand surgeon was taking care of the hand. Later at CVS, the nurse administering a vaccine to Susan said that she had quit working in the emergency room at BWMC because of the stress from understaffing. Please support Senate Bill 720. Thank you.
Thank you, Ms. King. Christopher? Oh, wait a minute. You can go next. Okay.
Good afternoon, Chair Bidle and members of the committee. My name is Erika Puentes. I am the legislative coordinator for Progressive Maryland. Progressive Maryland is a statewide grassroots group working for a more robust, equitable, and patient-centered healthcare system. We are proud to be part of the Patient Worker Collaborative, a coalition representing more than 1 million Marylanders that have come together to raise concerns about ER wait times and the ongoing hospital staffing shortage that contributes to them. Like all of you, we regularly hear stories from our members about very long and frustrating wait times in emergency rooms. During a recent member call, one of our members shared a story about waiting in the Hopkins ER from 5 p.m. until 9 a.m. the following day, an exhausting 16-hour wait before a doctor finally saw him. Given the critical staffing shortage in hospitals and the need for more nurses, the Safe Staffing Act of 2025 offers an excellent remedy to what is ailing our ER rooms. Creating safe staffing conditions will help our hospitals recruit and retain the workforce they need to meet Marylanders' needs. This legislation gives hospitals clear guidance to develop nurse staffing committees and staffing plans that will better serve the goals of staff retention, workplace safety, and most importantly, patient care. It's not acceptable for our state to have the worst ER wait time record in the country year after year. SB 720 will allow Maryland to join 9 other U.S. states who have taken steps to create blended staffing committees, staffing plans, and public reporting requirements to improve the way we deliver care. We appreciate you for holding a hearing on this important legislation. This bill got a supportive reception from your colleagues on the HGO committee, and we urge the Finance Committee to offer a favorable report on Senate Bill 720. Thank you.
Thank you. And now, Christopher.
Thank you, Madam Chair. Honorable members of the committee, my name is Christopher Cano, Director of Political and Legislative Affairs for SEIU Local 500. You know, usually I get up in front of you and debate the policy merits of the bill, but I think it's relevant to share a personal story in this. A few weeks back, you recall I had my 9-month-old son here with me testifying. What you don't know is that my wife, when she first found out she was pregnant, we waited in Johns Hopkins ER in Baltimore, as was actually just said, from 5 p.m. until 9 a.m. the next morning before she saw a doctor. I saw my own wife's aunt when she was visiting from Italy this past summer wait at Baltimore Washington Medical Center in Glen Burnie from noon until 9:30 at night before she saw a doctor just for a COVID diagnosis. Now, in both situations, my family came out on top with these situations, but everybody's not that lucky. My own mom works at Loomis Health in the hospital and recently has moved from working in the doctor's bariatric surgery to moving on the floor. And she can tell me, as a brand new nurse, even though she's been doing this for 40 years, that they're already understaffed. She's seeing 6 patients each and every night as a nurse. And sometimes they even have more. And the concerns that these folks are bringing up for these hospitals are real, and the consequences in people's lives are real. And this bill will do a lot of good and going a long way in having these hospitals address this in a meaningful way by hearing from the folks who are putting in the effort, who are doing the work. Because what I saw in their own experience of watching my wife sit there with uncertainty, not knowing what was wrong, was that there are folks that are overstaffed, that are understaffed, overworked, that patients were leaving. And that's probably one of the only reasons our queue even moved the way it did. People were just leaving because they were frustrated. And that just shouldn't happen, especially not in a state like this one. I mean, as you know, I come from Florida. I mentioned all the times, all the ways that you all get it right and they don't. But it's sad to see that they're getting it right and we are not, especially with the resources that this state has. I urge a favorable report in this bill.
Thank you, Christopher. Do I have any questions for this panel? Senator Ellis.
Yeah, thank you for your testimony. So, question, how is, say, Florida getting it right and we're getting it wrong? You made that statement.
I got this finger chopped off in Florida, and unlike the testimony that she gave, I got right into the ER, and within 15 minutes I was triaged, and within an hour and a half I had this finger reattached and signed up. That's just a personal anecdotal experience.
Yeah.
And so I think that's just one in my own experience. That's all I have is my own personal experiences, I could tell you.
So I thought you had an idea why they got it right.
Well, I would say the aging population, they're accounting for it, you know, but also they have the same issues that you all have systemically in the sense that they have an aging workforce among their nurses and that they're often not paying enough when it comes to the service technicians and other folks that are support staff in the hospital.
Okay, thanks.
Yeah.
Thank you, Manager.
Thank you, Senator. I don't see any other questions. That ends this panel. We have 2 more favorables, Ruth Carlock and William Reed. And then I'm going to ask Dana to come up. She's favorable with amendment, Dana Kaufman. And I'm going to start out with William Reed. When you're ready, sir.
Yes, good afternoon, Chair, Vice Chair, and Finance Committee members. My name is William Reed, and I'm a resident of Frederick, Maryland. I serve as a leader and board member of Progressive Maryland and chair of Frederick County Progressives, and also a leader on their healthcare task force. Today, I provide written testimony to support SB 720, the Safe Staffing Act of 2025, requiring Maryland hospitals to establish clinical staffing committees and implement staffing plans to ensure safe and effective patient care. SB 720 addresses chronic, short staffing issues in many Maryland hospitals, particularly emergency rooms and critical care departments. By creating staffing committees comprised of 50% direct care workers and knowledgeable medical staff, SB 720 ensures that those on the front lines have a voice in setting safe and effective staffing levels. Each committee will develop a clinical staffing plan tailored to hospitals' patient population, including clear guidelines on how many patients should be assigned per nurse, and the appropriate number of support staff per shift. To maintain hospital accountability, they must review and update their staffing plans annually, evaluating the effectiveness and making necessary improvements. Additionally, these plans will be posted on the hospital website, increasing transparency for healthcare customers and holding institutions accountable for safe staffing levels. SB 720 also ensures that safe staffing plans consider patients' acuity levels, discharge and admission rates, and healthcare providers' necessary skills and expertise, all critical factors in delivering high-quality care. Furthermore, hospitals must establish a process for receiving and addressing complaints related to staffing concerns, ensuring continuous improvement in patient safety. In conclusion, SB 720 is essential for protecting both patient and healthcare workers. Overburdened staff cannot provide the level of care patients deserve, and understaffing leads to burnout, high turnover rates, and worse health outcomes. The Safe Staffing Act of 2025 is necessary to ensure that Maryland hospitals remain a place of healing, not harm. I urge you to support SB 720 and take decisive action to protect Maryland patients and frontline healthcare workers. Let's build a healthcare system prioritizing safety, transparency, and accountability.
Thank you. Ruth Carlock.
Good afternoon, everyone. My name is Ruth Carlock with the Brain Injury Association of Maryland. The Brain Injury Association of Maryland has witnessed firsthand the profound impact that staffing shortages have had on clinical burnout. That staff shortages and clinical burnout have had on patients, particularly those who have sustained brain injuries. Individuals recovering from brain injuries require intensive, specialized, and often prolonged rehabilitative services. The success of their recovery heavily depends on consistent, personalized care provided by a dedicated team of healthcare professionals. This legislation offers a way for these hospitals to reduce burnout with a plan to address safety concerns. This legislation allows hospitals to create individualized plans to address the specific issues of each hospital much sooner than top-down legislation could achieve. However, chronic understaffing and the reluctant burnout among clinicians pose significant challenges to delivering such care. Research indicates that burnout is prevalent among professionals in the brain injury rehabilitative settings, often stemming from factors such as emotional exhaustion, depersonalization, and a diminished sense of personal accomplishment. These factors are exacerbated by high patient loads, insufficient resources, and the emotional toll of managing complex patient needs. A study exploring the experiences of support staff in traumatic brain injury rehabilitation center highlighted several themes contributing to burnout, including the unique challenges of, this paragraph got added twice. Right now, 1 in 4 nursing positions are vacant, and this crisis only stands to get worse with an aging nursing population and decreasing graduating rates of new nurses in the state, with numerous studies showing the link between excess nurse-to-patient ratios leading to worse patient outcomes and the increased number of unnecessary deaths, with the Health Service Cost Review Commission showing some patients waiting up to 20 hours to receive emergency care. Implementing the safe staffing proposed by SB 720 would address these critical issues by ensuring adequate staffing levels, reducing clinical burnout, and improving patient outcomes. Investing in appropriate clinical staffing is not only a moral obligation, but also a strategic decision that will benefit Maryland's healthcare systems in the long term. I urge this committee to issue a favorable report for SB 720.
Thank you, Ruth. And Dana, you're favorable with the amendment?
Yes. Thank you, Madam Chair, members of the committee. For the record, my name is Dana Kaufman, and I'm here on behalf of MedChi, the Maryland chapter of the American College of Emergency Physicians and the American College of Obstetricians and Gynecologists. You have our written testimony, so I don't want to repeat what you have heard from the previous panelists. I do want to point out that we are requesting an amendment. As the bill is written right now, a physician is only on the committee if it's a non-teaching hospital. If it's a teaching hospital, then it's a resident, and we feel that we need to have a physician on the committee if it's teaching or a non-teaching hospital. We're fine with a resident as well, of course. We love our residents, but we would like to have a physician. So thank you very much.
Thank you, Dana. Do I have any questions for this cap? Okay, thank you very much. Now we have 3 unfavorables. Kimberly Schwenk, David Hunt, and Andrew Nicholas. Are you ready?
Yes, ma'am. Absolutely. So thank you very much, Madam Chair. Members of the committee, my name is Andrew Nicholas, representing the Maryland Hospital Association, here today in respectful opposition to Senate Bill 720. I do want to thank the sponsor and the advocates for proactively reaching out to the Hospital Association and engaging us in conversations on this important issue. Maryland hospitals are absolutely committed to delivering quality and compassionate care to every patient. We are also committed to ensuring we provide a safe and supportive working environment for our employees. Ensuring appropriate staffing levels is a core function of hospital operations and a critical component to patient care. That's why hospitals have well-established and regulated guidelines to do this, overseen by multiple national accrediting agencies. Maryland hospitals are also committed to working with frontline staff in developing our staffing plans and our staffing levels. This is called the shared governance model, and it is something that we are embracing in hospitals across the state. So our opposition is in no way to the engagement with our frontline staff. The concern with Senate Bill 720 is that it lacks the critical flexibilities that hospitals need in order to respond in real time to staffing demands. You have to be able to respond to individual patient needs and acuity levels, fluctuations in volumes, bed availability. All of these things necessitate being flexible and adaptable in your staffing plans, and staffing committees therefore need to be flexible as well. That is why staffing committees that exist today have shared governance, but they exist at the individual unit level. And this flexibility is even more critically important when we are in the middle of a national workforce shortage like we are here in Maryland and in the rest of the country. And so we are concerned that Bill 720 does not reflect the complexities of clinical staffing and that it does not address the root causes of the workforce shortage. So therefore, we urge an unfavorable report. Thank you.
Thank you, Andrew. David, would you like to go next?
Thank you, and good afternoon, Madam Chair and members of the committee. My name is David Hunt, and I'm the Chief Nursing Officer at the University of Maryland, Baltimore, Washington Medical Center in Glen Burnie. I've been a nurse for 35 years and in nursing leadership roles within the University of Maryland Medical System for the last 16 years. I'm here today in respectful opposition to Senate Bill 720. BWMC, Baltimore Washington Medical Center, is nationally recognized by the American Nurses Credentialing Center as a Pathway to Excellence organization. This means we're committed to nursing growth and clinical excellence. The University of Maryland Medical System is very deliberately partnering with academic practice partners to improve hospital staffing resources. Our novel and innovative Academy of Clinical Essentials program and our new community pathway programs are working to try to expand the workforce and increase the pipeline into our industry. As mentioned, hospitals already have well-established processes for determining appropriate staffing levels, guided by nationally recognized accredited bodies like the Joint Commission, the Centers for Medicare and Medicaid, the American Nurses Credentialing Center for Nursing Excellence Programs, and other professional standards. These organizations set rigorous requirements to ensure safe, effective, and high-quality patient care. We are not convinced that staffing committees are the best option for our teams and for our industry. There are other best practices that are more flexible and responsive to the changes in patient complexity and acuity. This bill does nothing to help solve the shortage of nurses and other allied health professionals, and staffing ratios do not balance clinical workload for healthcare team members and are already subject to federal regulations. So for these reasons, I respectfully request an unfavorable report on SB 720. Thank you.
Thank you. And Kimberly?
Good afternoon, Madam Chair and members of the committee. For the record, I am Kim Schwank. I'm the Chief Nursing Officer at MedStar Franklin Square Medical Center, and I'm here in respectful opposition to Senate Bill 720. Franklin Square is an acute care hospital located in Rosedale and sees approximately 130,000 patients annually. We are the largest of 7 MedStar campuses in Maryland with 357 licensed beds. In this role, I oversee 800 registered and licensed practical nurses, as well as approximately 300 ancillary professionals. We are a 4-time designated magnet facility that prides itself on the clinical excellence and innovation brought forward by our teams. Limiting this innovation would hamper the clinician's insight and expertise. Nursing decisions that have been brought forward by our clinical teams focus on staffing, capacity, and throughput. Volumes and acuity can shift in the moment, and an annual static plan will limit the changing need we provide our patients. Our ED sees 67,000 visits annually, and through our FAST emergency department and innovation brought forward by our frontline clinical nurses, we see 2,500 patients per month. Proudly, we have staffed all of our acute care beds, and none of our beds are closed due to staffing. Our current vacancy rate is 6%, and currently with less than 30 agency resources housewide. We are the fastest offloading emergency department in Baltimore region with minimal diversion due to capacity. A metaphor that is assimilated to traffic in the lanes of a highway is if you add more lanes, you would reduce traffic. That just adds more lanes and more cars. The same metaphor can be applied to the capacity of a hospital. If you add more beds, it doesn't offer more efficiencies, it just adds more patients in the beds. Our nurses presented plans to address the bottleneck of the acute admission. This included the FAST ED, the Discharge Hospitality Center, and our throughput councils. Our workflow designs come from our council structuring involving nurses and the clinicians of all disciplines at the beginning of the process as part of the solution. Monthly throughput committees and daily capacity huddles review metrics, outcomes, and impacts to patient care. Our float pool and proactive pooling needs of the Discharge Hospitality Center and our clinical nurses have optimized our patient volumes. We have the largest float pool. The flexibility is what the nurses are asking for, so the innovation regarding flexible workforces is what is needed to solve the challenges of throughput and capacity. Thank you for your consideration of this testimony, and I urge an unfavorable report of Senate Bill 720.
Thank you. I'm going to ask a question to Andrew. So, tell me about the nursing shortage. How severe is our nursing shortage, and does this bill do anything to address the root causes of the nursing shortage?
So we have a significant nursing shortage. You heard before, 1 in 4 nurses across the state, a vacancy rate of 1 in 4 nursing positions, and it is true across the country. And so no, unfortunately, this bill does not do anything to address those root causes. What we're seeing is really a kind of a generational moment, with the largest generation in the history of our country aging into retirement, at the same time coming back to hospitals seeking more care for services as they get older. And unfortunately, we have a generation coming up, as you also heard from proponents, that are simply not choosing careers in the healthcare space. And it's not limited to hospitals, this issue, this workforce shortage issue. It is across multiple critical services. I was able to participate on a panel at the Summer Mako this year on workforce issues, and it was with leaders from fire chiefs from across the state, police chiefs, EMS leaders, all facing the same issues. Interestingly, in the case of the fire department, historically, they've never had to recruit. They've typically have had to turn people away because it was a profession that kids grew up aspiring to be, and they're having to develop recruitment practices for the first time ever. And it's anecdotally, the fire chief that was there noted that it's just, you were seeing fewer and fewer young people interested in these positions. In his daughter's 5th grade class, the #1 profession that those kids wanted to be at 5th grade was a social media influencer. And that's what we're facing. I've got a 17-year-old nephew who wants to make his living playing video games, and unfortunately, there's a pathway for him to do that. It's not as crazy as that used to be. And so hospitals have been leading and waving the flag on the critical nature of the workforce shortage, working with you all on many legislative solutions to try to increase recruitment and have loan forgiveness, partnering with our community colleges, going even deeper into high schools and younger ages to bring people in. So those efforts are there. It will take time to get things where they need to be, but it is not just hospitals, it is across the board.
I'm going to ask David a question, because I know you're Director of Nursing at BWMC, correct?
The Chief Nursing Officer,
Chief Nursing Officer. So tell me about the results of your recruiting. Have we seen some increases in nursing at BWMC because of the recruitment efforts?
So we have. We're trying to be innovative, and I mentioned practice partnerships with our university schools and colleges. The Academy of Clinical Essentials program is a different program by which University of Maryland Medical System nurses are working as instructors to bring a much larger pool of students into the workplace. And so as a consequence, the students, nursing students, we have now about 800 or 900 every semester coming into our hospitals for very real experiences partnering with a professional nurse. The impact of that is, rather than getting an academic experience where they sit in a classroom adjacent to a hospital, they're actually providing direct care to patients, meeting with families, rounding with doctors, giving medications, assessing patients, et cetera. The reality is that they're far more prepared when they come into practice roles. And so we're seeing a significant increase in the number of nurses that are coming into those roles. We're engaging them differently as a consequence. We did hear about an aging workforce, but many now of our nurses are coming in as much younger nurses, and we're learning from them as they come in. We have a very interactive relationship with them. I think the final point is that we've seen a corollary first-year RN turnover reduced by quite a significant amount. So a year ago, our first-year RN turnover was at 36%. Today, it's at 17%. Our nursing vacancy a year ago was at 24%. It's at 8%. And our overall turnover was 24% a year ago. It's running at 16% and continuing to drop. We have to innovate. We have to partner differently with our academic colleagues, and we have to create growth opportunities and support structures for our nursing teams.
Your hospital has done a lot to recruit nurses. Can you tell me what your vacancy rate was last year and what your vacancy rate is this year?
So I've been the chief nursing officer at MedStar Franklin Square for 3 years. When I started 3 years ago, we were at a 40% RN vacancy rate, and I'm proud to say that we're at a 6% RN vacancy rate now. Our turnover 3 years ago was at a 9% for our nursing clinicians. We're at 1.3%. It's a lot of the innovation that David has spoken about as far as engaging with our teams and partnering with our frontline resources, involving them in the decisions and the plans, and having those touch points with our academic partners, providing innovation and academy structures to promote the growth and development from within the organization.
Thank you for that. Senator Ellis, you have a question?
Thank you, Madam Chair. Being on the ground, thank you for your testimony. And know a lot of nurses have kind of left the profession over the years. They still have their education and experience because of work conditions, staffing conditions, and overwork and under respect. They kind of leave. Do you think there's a way to re-engage those nurses who are out there basically because of frustration with maybe administration? I'm not sure who wants to address that.
I'd be happy to as well.
Yeah, so we have what's called a boomerang program, and we bring nurses who've previously left us or retired that want to come back into the workplace. Part of the element of that is engaging with them and giving them a voice in our professional practice structures, and giving them the opportunity to teach and to train and to actively lead in the work that they do. But we've been very successful, and part of the numbers that I shared with you, and I suspect is your similar story, is the ability to engage with those people because they have many years of experience, and you simply can't replicate that level of wisdom.
Yeah, numbers I saw years ago, it's like for every nurse that's actively working, there might be 3 or 4 that left the profession over the last 15 years. So with a policy like this, staff and committee at this bill, wouldn't you think that it'll send those nurses who have exited the profession a message that, you know, they will be more engaged, and we want to kind of make you part of the problem and bring more of them back in?
Well, I can speak to what we have currently as a Patient and Family Advisory Council. We have nurses that sit on our council, and we actually bring decisions related to staffing to them for advisement. Much like David, we have a boomerang structure as well, and using the current technology that we have available through a virtual nurse program, they're more of a resource, a phone-a-friend help that can offer that support. It also allows the aging workforce in nursing that flexibility, like I had referenced in our outcomes, to be more of a virtual on their time and on their schedules so that they're available when they can be that resource, rather than mandating a certain amount or a certain time or a certain shift.
Yeah, okay. So what's that committee you said, the name of that committee you have, ma'am?
It's a Patient and Family Quality Advisory Council.
Patient
And Family
and Family
Advisory Council.
Advisory Council. Okay, so the nurses are on that council?
I have 4 retired nurses that participate on that council.
So where is the administration in that?
That's me, and I have risk management, and I have multiple nursing directors that participate in the committee as well.
So you just don't like the more formal?
We already have the staffing committees. We have, throughout a 24-hour period, our clinicians meet about 4 times through the day. And then from a system perspective, we have a 7:30 capacity call that evaluates all of the capacity over all 10 hospitals, and then also at noontime. So we have an ongoing structure to evaluate the capacity and staffing.
And you think that's working?
I think it's working excellently.
Okay, wonderful. Thank you. Thank you, Madam Chair.
Senator, I don't see any other questions for this panel. Thank you.
Thank you.
We have one more witness for this bill virtually, Nadine Williams. If you'll unmute and give us your testimony, please.
Thank you, Madam Chair. My name is Nadine Williamson, and I proudly serve as the Executive Vice President of the RN Division of 1199 SEIU. I'm a registered nurse for 15 years. In 2021, I worked alongside union members, hospital leaders, and legislators to help shape New York's Safe Staffing Committee legislation. That's why I fully support Maryland's Safe Staffing Act of 2025. Healthcare workers bring an unmatched level of expertise from being at the bedside every day. And when hospitals truly listen to this expertise, care improves. I've also long believed that labor management collaboration is essential when both workers and management are committed to improving patient care as their shared goal. Real change happens. Staff feel valued, recruitment and retention improve, and patient outcomes get better. But for collaboration to work, it must be built on a foundation of respect, accountability, and shared decision-making. New York's hospital staffing committee law is built on this foundation. It requires frontline workers and management to sit down as equals, listen to each other, and develop staffing plans that work in the best interest of patients and workers. But here's the reality. Collaboration doesn't always work if one side has the ability to override the process. In New York, we've seen that in hospitals with a strong history of labor management partnership, the staffing committees are making real progress. Workers feel heard, issues are being addressed. However, in hospitals where labor management relations have been contentious, the process has been far more difficult. This is where we've seen a flaw in New York's law, setting clear expectations for how the process should work and what plans should include will help both sides. Maryland has an opportunity to learn from New York's experience and build something even stronger. I encourage Maryland to recognize that labor management collaboration takes time and effort. Strong training programs can help build the skills needed for real partnership. And as you move forward, remember that your proposed legislation wisely calls for annual plan evaluations and updates, giving you a chance to assess what's working, make necessary adjustments, and strengthen accountability. Safe staffing is a fight we must continue. New York's journey is not over, and Maryland's won't be either. But by learning from our challenges, you can pass a law that truly empowers workers and puts patients first. Thank you.
Thank you very much. Do I have any questions for this witness? I see no questions. Thank you very much for your testimony. And that ends the hearing on Senate Bill 720. It ends our hearings for today. Senator? Oh, thank you. Ends our hearing for today. And committee, stay close because Tammy's going to get us ready to vote.